Good morning. My name is James Valentine, and welcome to the externally led patient-focused drug development meeting on GM1. I'm here in the studio with my co-host Christine Wagoner, who's the founder of the Cure GM1 Foundation, and we're coming to you live from the Washington, D.C. metropolitan area, actually not too far from where the U.S. Food and Drug Administration's headquarters are located. It's my pleasure to turn it over to Christine to provide some welcoming remarks. Christine?
Thank you, James. Welcome, everyone, to the externally led patient-focused drug development meeting on GM1. I'm Christine Wagoner, founder of the Cure GM1 Foundation and mom to my daughter Iris, who has juvenile GM1. Our mission at the Cure GM1 Foundation is to help support the drug development process, to fund GM1 research, and to help support the global GM1 community. Since founding Cure GM1 in 2015, our group has been in contact with families impacted by GM1 every day. I personally know over 600 individuals and families affected by GM1 worldwide, including bereaved families. These are the people for whom this meeting is for today, and whom we strive to help. My involvement with Cure GM1 is personal since my daughter Iris was diagnosed with juvenile GM1 at age 5. When she started kindergarten, we struggled to convince the school she needed any support. By the end of kindergarten, the school had seen the rapid, progressive degeneration of her abilities. She is now 14 years old, and her condition is advanced. I intimately understand this disease. I know the true devastation firsthand. I'm here for our family, but also for the entire global GM1 community. As you will hear and see today, many living with GM1 are severely affected, and this disease is truly devastating and fatal. GM1 destroys the brain and spinal cord and impacts many organs. There are no FDA-approved treatments for any of our disease manifestations. We urgently and desperately need treatments for people living with GM1. While listening and learning today, I ask that you listen carefully to our stories and imagine what our lives are like. We hope and expect this meeting will encourage future research and successful new product development for all those living with GM1 who urgently need treatment options as soon as possible. Thank you to the U.S. Food and Drug Administration for giving us permission to hold this meeting and for attending. We're incredibly grateful for this opportunity to share our experiences with you. Thank you also to our generous supporters who financially sponsored this meeting, who are too numerous to name individually. Our platinum and gold sponsors are Cyogene Therapies, Passage Bio, and Azapharos. We are really pleased to have in attendance representatives from advocacy groups, biotech companies, federal agencies, and research groups throughout the world. And to the people with GM1 and caregivers, thank you for participating. This meeting is for you. We invite you to call or write in during the program and ask that you participate in the remote polling as well. We want to hear as many perspectives as possible. Understand that we will do our best to get to all your comments. Please only use your first name and no other identifying information should be shared. Those comments that we cannot get to will be just as important because they will be collected and published in the Voice of the Patient report, a comprehensive summary of this special day. Let's get started. To begin today's meeting, I'm thrilled to introduce Dr. Wilson Bryan. Dr. Bryan is the director of the Office of Tissues and Advanced Therapies in the Center for Biologics Evaluation and Research, CBER, at the FDA. Dr. Bryan will provide some opening comments from the FDA perspective. Dr. Bryan?
Good morning. Thank you for that kind introduction. I appreciate the opportunity to say a few words on behalf of the FDA. This year is the 40th anniversary of my graduation from medical school in Chicago. I've been a doctor for 40 years now, and I've seen thousands of patients. But in those 40 years, I don't believe I ever saw a patient with GM1 gangliosidosis. So I am here today, along with representatives from both the FDA Center for Drugs and the Center for Biologics, because medical education is a lifelong process, and we all need to continue to learn. To prepare for this meeting, I started by looking up GM1 gangliosidosis in Wikipedia. In Wikipedia, there's a section on the cause, which told me that these disorders are due to genetic mutations. Well, I knew that much already. And there's a section on the diagnosis, which told me that there are 3 forms: early infantile, late infantile, and adult, and provided just a few sentences describing the 3 forms. The next section on the Wikipedia page was treatment. And that section says, this section is empty. You can help by adding to it. And that is why we are here today, to do whatever we can to develop a treatment for GM1. At the FDA, we have the privilege of working on the development of a variety of new treatments, including devices, drugs, and gene therapies. My understanding is that there are both small molecules and gene therapies under development for the treatment of GM1. Over the past few years, the FDA has approved several gene therapies, all for the treatment of rare disorders. What is most encouraging is that these gene therapies have dramatic effects. The gene therapies that have been approved by the FDA are life-saving and life-changing products. Also, for 2 of the FDA-approved gene therapies, the clinical trials to prove the effectiveness of each product required less than 50 patients each. I am confident that the years ahead will bring effective treatments for GM1 gangliosidosis, and that the necessary clinical trials will not require a large number of patients. Today's meeting will serve to advance the development and regulation of such new and better treatments for GM1. These new treatments may be innovative devices, new life-changing small molecules, or cell or gene therapies. Particularly, what we learn at this meeting will help the FDA to think about how clinical trials should be designed. What endpoints are meaningful to patients, and how to balance benefits and risks of a new product. I would like to thank the many generous sponsors of this patient-focused drug development meeting, and more importantly, for the work that is being done to develop new treatments for GM1. Drug development is not easy. It requires many years of scientific research and a commitment of substantial resources in the effort to make life better for patients. All of us owe a debt to those of you for your commitment and effort. Which reminds me that as physicians, most of our education comes from our patients. And that education usually comes from spending time with individual patients. And the more individual patients that we spend time with, the better educated we become. GM1 gangliosidosis has a variety of clinical manifestations. No 2 patients are exactly alike. So it is critical that we hear the many individual voices of the members of the GM1 community discussing the full range of challenges that you are facing. Therefore, I would like to thank the Cure GM1 Foundation for organizing this patient-focused drug development meeting, and particularly thank you, the patients and caregivers who we will hear from today. Those of us at the FDA need for each of you to continue to speak up, and we will continue to listen. Back to you in the studio.
Thank you, Dr. Bryan. And now I would like to introduce Dr. Cynthia Tift, who will be presenting a clinical overview of GM1 to help create a scientific foundation for the rest of today's meeting. Dr. Tift is a Deputy Clinical Director at the National Human Genome Research Institute, and she has studied lysosomal storage diseases for 40 years. She is the principal investigator of the first gene therapy clinical trial for GM1. Over to you, Dr. Tift.
Thank you very much for that kind introduction, and good morning, everyone. I realized as I was putting this talk together that this year marks the 40th year I will have been dealing with lysosomal storage diseases. So not to tell you how old I am, but you can figure it out. So today I would like to talk about GM1 gangliosidosis and give you just a little snapshot before you hear from patients and families about this important disorder. Lysosomal storage disorders, of which GM1 is a part, are multi-system and collectively common disorders, and many of them involve the brain. Individually, GM1 is about 1 in 100,000 to 200,000 live births, but collectively, lysosomal storage disorders are about 1 in 5,000 births, so they're actually quite common. And about 70% of them involve the brain, as you can see here on this illustration. So let's talk about lysosomal storage disorders, what they are, what is a ganglioside, and what is GM1 gangliosidosis. When I began giving talks about LSDs, I used to always say the lysosome is the cell's recycling center. So if you can imagine, the circle is the lysosome, and there are various bins that you can throw your trash, your garbage, your paper, your plastic. And what happens in lysosomal storage disorders is one of the bins, one of the baskets gets full. And when that happens, the glass, for example, illustrated here, begins to collect. And sooner over time, the glass piles up, and suddenly you have a whole lysosome filled, or a whole recycling center here filled with glass. Well, once all the pileup happens, it's impossible not only to recycle glass, but also paper and plastic and garbage. And over time, this lysosome really becomes non-functional. That was kind of our old understanding. Now we know that lysosomes are really the center of the cellular universe. Not only are they responsible for recycling, which is what we'll be talking about today, but as you can see here in the green square, they're also very important for nutrient sensing and the control of energy metabolism in the whole cell. So that an impairment of lysosomal function really impairs the whole cell, and it makes sense why the disorders we're talking about today are so life-limiting. What I've placed up here in the top is sort of a schematic of the lysosomal membrane, and I'm going to use that to kind of try to make sense out of lysosomes, gangliosides, and GM1 gangliosidosis. So here you see the lysosomal membrane. It is a collection of lipids, these green things, which are, I say here, are oil, which are really fatty, greasy substances, and these little head groups, which are more water-loving or soluble in water. And inside the plasma membrane are these structures we call lipid rafts. These float throughout the plasma membranes, and they contain very important things. They contain proteins, they contain these transmembrane proteins, they contain cholesterol, and they also contain gangliosides, particularly in the neurons, where the gangliosides are really predominant in the neurons. So these lipid rafts are components of cell membranes, And they're enriched, as I said, in cholesterol, glycosphingolipid, and receptor proteins, and they're really essential in cellular processing, including cell-cell signaling, for which one can imagine the neuron is very important. And gangliosides are constituents of these lipid rafts. So what is a ganglioside? If you take these ganglioside structures, let me go back for a minute here, that are called ganglioside, and you flip them 90 degrees to the left, you see the schematic that I've drawn here. There is a head part, a water-loving part. These are sugars, they're soluble in water. And then there is this fatty piece that goes down into the membrane. It's called ceramide, and they are hydrophobic or phobic, water-hating molecules. Okay, so that's a ganglioside, but what is GM1 gangliosidosis? And really the name tells you exactly what it is. It's GM1 ganglioside, and osis in medical terms is usually a disease state that results in abnormal production or an increase in whatever it is we're talking about. So in this situation, this is an increase or an overabundance of GM1 ganglioside. And in this case, not because it is overproduced, it's because it is not broken down and accumulates in the cell. So GM1 gangliosidosis is a disorder of ganglioside degradation. It's caused by mutations in a gene called GLB1. And GLB1 produces an enzyme called beta-galactosidase. And so another name for GM1 gangliosidosis is beta-galactosidase enzyme deficiency. So as we saw in some previous slides, it is the inability to cut off this first sugar from GM1 ganglioside. Unfortunately, if you can't cut off the end or the terminal sugar, you can't break down the molecule any farther, and that's why GM1 is stored in lysosomes. This is a rare neurodegenerative disorder that is uniformly fatal and unfortunately right now has no approved therapies. It is pan-ethnic, that means it occurs all over the world, and it has an incidence, as I mentioned, of about 1 in 200,000 live births. So let's go back to our schematic. Lysosomes, the center of the cellular universe. Beta-galactosidase enzyme resides in the lysosome. This is a rather acidic environment, and in fact, beta-galactosidase, the lysosomal beta-galactosidase, doesn't even work unless it's within the lysosome. And inside the lysosome, in addition to beta-galactosidase, are 40 or 50 other lysosomal enzymes that are responsible for similar things, breaking sugars down off gangliosides and other sphingolipids. So what happens, as I explained to you, and this schematic will show you probably better, GM1 ganglioside can be cleaved to remove the terminal galactose. And that happens if you have beta-galactosidase in the lysosome. The schematic here shows you that off the membrane, pieces are taken back into the cell for recycling, for degrading GM1 and allowing it to reform into other constituents. They traverse into the late endosome, and they finally make their way to the lysosome where beta-galactosidase breaks them down. However, if that is not possible because there is no beta-galactosidase, the lysosome begins to accumulate and accumulate more and more GM1. And eventually it accumulates so much that the lysosome becomes non-functional. It can't do the jobs, the other jobs it's supposed to do, like nutrient sensing and energy metabolism, and the whole cell suffers, and eventually, unfortunately, the whole cell dies. And in the case of neurons, when neurons die, they are not replaced. So the result are the symptoms that we see in GM1 gangliosidosis. So GM1 is really a continuum, which means that disease severity is directly related to the amount of residual enzyme activity one has left. So there are many, many mutations in the GLB1 gene that will produce beta-galactosidase deficiency. Some are more severe deficiencies than others. If you have essentially no beta-galactosidase activity, that is the most severe disease. If you have a little bit of residual function, say up to 5 or 10%, you can have a more mitigated disease. So we describe these in 3 different types. Type 1 is the infantile disease with onset very early, before 6 months. Low muscle tone, developmental arrest, enlarged liver and spleen, and a characteristic finding in an eye exam called a cherry red macula. Patients also develop seizures, they become blind, they have skeletal changes, and they generally die by about 2 to 3 years of age. Type 2, or what we sometimes call type 2A, is the late infantile onset form, which begins at about 12 to 24 months, often with impaired ambulation. What I mean by that is difficulty learning to walk well or increased falling. They also have lack of or regression of speech. These are children that usually develop single words. Sometimes they begin to put them together into 2 or 3 word phrases, but then they lose the ability to do that. Decreased cognition. Some have skeletal disease, others do not. Eventually they develop seizures, and death usually ensues in the mid-teens. The type 2B, or juvenile disease, has an onset between ages 3 and 6. They also have impaired ambulation. Now, generally, these are children who learn to walk and run, and then will begin to fall and trip and have an unsteady gait. They also have progressive, what often parents describe as stuttering or difficulty understanding the speech. They have decreased cognition over time and variable skeletal disease. Some have severe skeletal disease, some do not. And these children, I say, survive at least into the 4th decade, because 2 of my oldest patients are now in their early 30s. And lastly, there's the type 3, or adult onset disorder, which is very uncommon in this country, and it features gait disturbance, dystonia, dysarthria, or impaired speech, decreased cognition, and quite a variable range in age at which patients die. So I think this schematic tells us about sort of the spectrum of disease in GM1. The most severe disease, the infantile disease, is much more homogeneous in infantile patients, and the less severe, more heterogeneous juvenile onset disease really has onset at varying times and spreads over a much wider range for phenotype, and the late infantiles fall somewhere in the middle. This heterogeneity in disease onset and in disease progression makes demonstrating improvement with a therapy, for example, over a short period of time exceedingly difficult for these type 2 late infantile and juvenile onset patients without extending a clinical trial for years and years. It just makes doing clinical trials quite difficult in these children. GM1 gangliosidosis is what we call an autosomal recessive disorder. This implies that the mother and father are both carriers for a mutation in GLB1. One copy of their GLB1 gene has a mutation, the other one does not. They are perfectly healthy. But when we go to have our kids, we only can pass 1 copy of each gene, as you can see illustrated here. 1 chance in 4, both parents pass the copy that does not work well, and the child will have GM1 gangliosidosis. So the chance for having an affected offspring from 2 carrier parents is 25%, or 1 chance in 4 for each pregnancy. Healthy offspring, these 3, you can see here, and 2/3 of them will be carriers of the disease. Reproductive options are quite limited without early diagnosis, and I will explain that in the next slide. Diagnosis is taking much too long. This is my cohort of patients at the NIH. We have 41 patients. 30 of them are probands, or the index cases. The others are siblings. We have 17 late infantile patients and 24 juvenile patients. But the median time to diagnosis for our late infantile patients was 17.5 months after the onset of symptoms. And truly, the median time to diagnosis in our juvenile patients was 10 years after the onset of their symptoms. That is way too long to begin to think about therapy. There are many mutations in our cohort of 41 patients. There are 36 different mutations. The presenting symptoms, as I've discussed before, are really gait disturbance and poor speech or stuttering. And early diagnosis including newborn screening, is really, really key for successful treatment. I cannot emphasize that enough. It is difficult to think about how we treat these patients if, in fact, they've really had symptoms of their disease for months to years before we can even intervene. So now I would invite you to sit back and listen to the families begin to tell their stories much more eloquently than I could ever do. It's back to you.
Thank you so much, Dr. Tift. I'd now like to welcome our moderator for today's meeting, James Valentine, who has been working with us over the past several months as he's helped us plan this meeting. James has worked the last 14 years as a champion for the patient voice. James previously worked at the FDA, where he was a patient liaison, helping to incorporate the patient voice into medical product review. There, he helped to develop and launch the Patient-Focused Drug Development Initiative. In private practice, James has worked with many patient organizations to ensure their community's voices were heard by decision makers. Relevant to today's meeting, James has been involved in helping plan and moderating 3/4 of over 60 externally led PFDD meetings. So we're in good hands with James.
Well, thank you so much, Christine, and it's such a pleasure to be with this GM1 community this morning, and I'm looking forward to hearing so many of your voices today. So, now that we've heard a clinical overview from a disease expert, we turn really to the core of today's meeting, which is to hear from you, the families and direct caregivers of those living with GM1. Patient-focused drug development is a more systematic way of gathering patient perspectives on their condition and on available treatments. As you heard from FDA's Dr. Bryan, your input can help inform the agency's understanding of GM1 to inform drug development and review. While FDA has held many of its own patient-focused drug development meetings, today marks the 65th externally led patient-focused drug development meeting. With over 10,000 known rare conditions, this is truly a unique and important opportunity for this GM1 community. Today's meeting is interactive, so let me tell you a bit about what we'll be asking of you and how today's meeting will be organized. The meeting itself is broken into 2 overall sessions. In our first session, which is what we'll be working through this morning, we'll be exploring the patient and caregiver experience with living with GM1 and its impact on your loved ones' daily lives. In our second session, which will be this afternoon, we'll bring everybody back together to explore the various approaches to treatment, including participating in clinical trials. And we'll also be asking about your preferences for future treatments. So what will these 2 discussions look like? Well, today we'll be using a few different methods to hear your voices. First, for each of our 2 sessions, we'll hear from a panel of caregivers of individuals with GM1 who were selected to help set a good foundation for this discussion, given their range of different experiences with GM1. But we know that no individual panel can represent the full range of experiences. So after we hear from those individuals, we'll broaden the discussion and bring all of you who are tuned in today into our live audience and offer you the opportunity to build on what the panel has shared. I'll be asking questions and inviting you to state your name and the subtype of GM1 that you represent and provide a comment. This can be done in one of 2 ways. We'll want you to dial in by phone, and I'll be sharing that number throughout the program. You'll also be able to submit written comments. There's a little comment box on the live stream webpage where throughout the program you can submit any written comments as well. You'll also notice that we'll have a Zoom panel of caregivers who will also be participating in those discussions. Finally, we're going to broaden the discussion through use of live polling questions. Patients and caregivers only will use their phones or use a web browser on the computer you're following along with today to answer those questions so we can see the results in real time. And in fact, we're going to go ahead and get you into this polling system now, because in just a few minutes we're going to get to our first set of polling questions. And once you're in this system, you can stay on it throughout the entire day. You won't need to do anything else. So at this point, we want to invite you to pull out your phone open up a browser. If you're following along on your computer, you can open up a new tab in your web browser and go to www.polev.com/GM1PFDD. Again, feel free to go there now, www.polev.com/GM1PFDD, and we'll get to polling very soon. These polling questions will broaden the discussion and include all of our community members that are on live today, and will help to serve us in aiding in the discussion as we get a sense of our audience's experiences. I also want to mention that after today's meeting, we'll additionally have an opportunity for further written comments for 30 days after the meeting today. And all of today's input, as well as any additional written input we get, will be summarized in a Voice of the Patient report, which will be both provided to FDA as well as made publicly available for researchers and drug developers to reference. So before we get started, I would like to go over a few ground rules for today. We encourage individuals with GM1 and their caregivers to contribute to the dialogue. As I've mentioned, this can be done through polling, calling in, and submitting written comments. The discussion is limited to patients and family members and their direct caregivers with living and experiencing GM1 on a day-to-day basis. Meanwhile, those who are tuned in from the FDA, drug developers, clinicians, they're all here to listen. I also want to note that views expressed today are going to be inherently personal, and the discussion may get emotional at times. So, respect for one another is paramount. And to that end, we ask that you try to be focused and concise in the comments that you share, so that way we can hear as many voices as possible, as Dr. Brian from FDA said is so important for today. So let's go ahead and get into it. Let's go to our first set of polling questions, which will give us a sense of who we have in our audience today. So again, this is for our GM1 community members. Go ahead and go to that browser you opened up on your phone, that tab that you opened up on your web browser on your computer. Again, this is www.polev.com/GM1PFDD. Once you're on this web page, you can just keep this up for the rest of the day. Anytime we get to a new polling question, you will be able to just go back to this page. It will automatically show up there. So we just want to make sure at this point everybody has a chance to get into this system, so that way you're there and able to answer these questions throughout the entire day. So in our first question for you today, we want to know what subtype of GM1 gangliosidosis does your loved one have? And the options are A, type 1 infantile, B, type 2 late infantile, C, type 2B juvenile, or D, type 3 adult onset. As the day progresses, these questions will get a little harder to answer, as we'll have you weigh in and kind of evaluate your experiences and share your thoughts and preferences. But we're going to take a few extra moments here on these early questions, because we do want to make sure everyone has a chance to get into this polling system, and so we can track your responses throughout the whole day. So it looks like a little over half of our participants today are representing those with type 2 late infantile GM1, about a quarter representing type 2B juvenile, around a fifth representing type 1 infantile, and about 5% representing type 3 adult onset. We want to hear from all of these experiences, both those that are, the ones that are most represented, as well as from those of you who are in some of the less represented subtypes. We want to hear about that full spectrum of different experiences that was covered in the clinical overview. We want to make that real and understand your experiences. So we go to our second polling question. Here we want to know, where do you or your loved one with GM1 currently reside? The options here are A, U.S. Pacific time zone, B, U.S. Mountain time zone, C, U.S. Central time zone, D, U.S. Eastern time, E, U.S. Alaska or Hawaii time, F, Europe and the UK, G, Middle East, H, Asia, I, Canada, K, Mexico, L, Africa, M, Middle East, N, Central or South America, or O, some other country or region not listed on this as a response option to this polling question. So we'll give you just a few more moments here to answer this question. It's looking like we have a good spread of representation across the different U.S. time zones, with the greatest representations in the Eastern and then Central time zones. It looks like we do have some representation from outside of the U.S., both in Canada and Europe and the U.K. We do welcome those of you who are from outside the U.S. We absolutely would invite you and love to hear from you throughout today's session as well. All right, if we can move to our third polling question. Here, we want to know, is your loved one with GM A, female, B, male, or C, other? So again, we'll give you a few moments here. Again, these questions are just to get a sense of, the people living with GM that we have, GM1 that we have represented in our audience today. Again, we want to know, is your loved one with GM1, A, female, B, male, or C, other? I see responses keep coming in, and it's bouncing around about 50-50%, male and between male and female, with that kind of bouncing back and forth over, which is slightly over, which is slightly under. So we have a pretty equal distribution of both people living with GM1 that are both female and male today. We go to our fourth polling question. Here, what is the affected individual's age? So the options are A, under 12 months, B, 1 to 2 years of age, C, 3 to 4 years of age, D, 5 to 10 years of age, E, 11 to 20 years, F, 21 to 30 years, G, 31 to 40 years, H, 41 to 60, or I, if older than 60 years of age.
Yes, so what this is showing is that it's primarily a pediatric disease.
Yes, we're seeing lots of responses across the different pediatric age ranges, particularly between ages 1 and 20. Currently, no one reporting being represented living with GM1 under 12 months. We do have some representation, though, of those who are in an adult age ranges in that 31 to 40 year age range. We do want to hear about life with GM1 at all ages, and again, across all subtypes. So we're glad to see that we have a number of the pediatric age ranges well represented here in today's meeting.
And in the literature, it says that the adult onset is most common in Japan.
Yes, I don't think we had any Japanese or Asia country representation today. Can understand that with the time zone differences right. Too. So if we go to our final polling question for this first batch of questions we have for you. So we asked about current age, but here we want to know, at what age was the affected individual diagnosed with GM1? And so here the options are A, between 0 and 6 months, B, between 7 and 12 months, C, between 13 and 24 months, D, between 25 and 36 months, E, if between 4 and 5 years, F, 6 to 10 years, G, 11 to 20 years, H, 21 to 30 years, I, 31 to 40 years, J, 41 to 60 years, or K, if you're unsure at what age the affected individual living with GM was got their diagnosis of GM1. So we'll give you, go ahead.
We absolutely believe that there are more adults out there. They just may not be diagnosed.
Sure. And knowing that we have most of our representation in pediatrics today, not surprising that diagnoses weren't in later years. But we did have some representation of those who are, between 11 and 20 years old. But we're seeing that none of those individuals were diagnosed in that same time frame. They were diagnosed clearly earlier, and we're seeing a good spread of different age ranges, 10 years and younger, that was when individuals were diagnosed, with the most common age of diagnosis being between 25 and 36 months, or 13 and 24 months. Okay, well, thank you for doing those polling questions. It was important to get a sense of who we have in our audience today. I promise the questions will get more interesting and honestly a little bit more difficult to answer as the day goes on. But at this point, I'd like to transition us into that first topic, that first session of today, which is really to understand what it is to live with GM1. If we could pull up our discussion questions for this morning session, we're going to explore the different symptoms and daily impacts of GM1, and we're going to ask that you call in and write in to help us understand, of all the symptoms and health effects of GM1, which 1 to 3 symptoms have had the most significant impact on your loved one's life. We're going to want to know how GM1 affects your loved one on best days and worst days. We know that there can be that day-to-day variability in the disease and its symptoms. We want to know also about how the symptoms have changed over time, and how the ability to cope with those changing symptoms might have changed. We know that once we hear a lot about those symptoms themselves, we do want to understand what that means in terms of impacts in daily life. So we're going to ask, if there are specific activities that are important to your loved one that you can't, or that they can't do at all or as fully as you think they would like because of their GM1. And also recognizing that while so much has already been experienced with living with GM1, that day to day you may also be thinking about life with GM1 in the future. And so we're going to ask for you to share what you fear the most as your loved one gets older, or what worries you the most about their condition. So to get us started on this topic of living with GM1, we're going to start with a panel of your peers, people that are direct caregivers of people living with GM1. We have Douglas, Abby, Bence, Megan, and Kylie. Douglas, take it away.
My name is Douglas, and I'm dad to my daughter Iris. When Iris was 1 year old, she couldn't have been more perfect. She hit all her milestones right on time. When she started kindergarten at 5 years old, none of the other parents knew or could tell anything might be different with her. But then her dexterity began to slow down. I had endured several lectures by teachers about how I wasn't doing enough and that it was my fault she was falling behind. She walked with her arms up a bit high and she couldn't jump, but that wasn't anything the other parents noticed. She had play dates. I know I have a parent's prejudice, but she had an enormous smile that made her very charming and popular with the other kids and parents. Cognitively, she was quite good. Now Iris is 14. She can no longer walk, talk, eat, scratch an itch, or make herself comfortable in any kind of meaningful way. When she moves, she can only rotate her head backwards, so her head gets stuck backward constantly in a way that limits her airways. For a couple years, she could have over 100 seizures in any given day until Epidiolex and Banzel medicine helped bring those much more under control. The 2-year journey of finding the right seizure medicine has left her with only 5 teeth on top. The one seizure medicine swelled up her top gums so much they burst the teeth off her skull. After 4 panic-filled days and a few misdiagnoses, I stopped the seizure medicine. The gum swelling stopped, but most of the teeth couldn't heal and fell out because she is a massive teeth grinder from the dystonia. During that time, she bit down on her tongue for 10 minutes before I could get her to loosen her jaw long enough to get her tongue out. For 8 months, she was in constant pain because the teeth left shards in her gum, but the hospital COVID restrictions kept her from getting the surgery she needed. A few months after getting her feeding tube, and during the time her seizures were raging, she lost 20% of her body weight from vomiting. Part of that is because the Banzel seizure medicine hurts her stomach. That theory has been proven correct the few times I tried to take her off of it. The doctor's suggestions never helped, but finally one of the parents suggested bolus feedings once an hour, which finally stopped it. Now she gained her weight back and 15 pounds more. As Iris's caregiver, I spend at least 15 to 60 minutes of every hour helping her. I feed her 12 to 13 times a day, change 10 to 14 diapers a day. Being very hydrated helps her dry eyes. Give her medicine 6 to 10 times a day. I give her about 70 to 80 minutes of physical therapy every day. She gets an enema every day so she can poop, and I hold her on the toilet for about 10 minutes. I sleep next to her bed on the floor every night to help her with seizures, nightmares, and her difficulty sleeping. I spend quite a long time trying to help her find TV that interests her, since distraction is one of the main forms of pain management. She's in pain or discomfort almost the whole day. She can no longer go to school without me after the school became overwhelmed with her having cluster seizures and throwing up every day. I spend 2 or more hours a day taking her to school. I take Iris everywhere I go because she is so tired of TV. I give her a 1 to 2 hour walk every day. I don't let myself relax or drop my guard because I'm sure to forget something. It's hard to know what my dreams are for her. With this disease, you learn not to hope for much because it will almost always lead to disappointment. I don't want to ever be frustrated with her. If I had to pick, I'd wish she could find peace and contentment. I wish she no longer had a pain look on her face much of the day. I want her to be happy. Iris is as sweet of a girl as you'll ever meet. Her favorite things in the world is to get people to smile at her. As she gets older, it's harder to find people to do that. She's ignored a lot by other people. Despite all her pain and discomfort, though, she rewards us with giant smiles from time to time. She deserves such a better life. As long as I never think, what do I want, it's fine for me, but no child or family should have to go through this. It's a joke in our family when my son says, "What would you wish for?" And it's always followed by, "I mean besides curing GM1. I hope someday soon you won't have to follow that question with that phrase.
My name is Abby. I live in Ogden, Utah with my fiance Cameron and my son Daxton. Daxton was diagnosed at 4 months with early onset GM1. Symptoms leading up to his diagnosis were aspiration, low oxygen, and low muscle tone. We noticed symptoms around 3 months old. The first symptom was Daxton aspirating on his bottles. We took him to his checkup at the pediatrician's office, and they admitted him to the hospital, where x-rays were taken on his chest to make sure he had no infection in his lungs. They noticed his ribs weren't symmetrical and 2 of his vertebrae were different than the rest. We were then referred to a genetic doctor who tested him for a couple of genetic disorders and ultimately came up with his diagnosis being type 1 GM1. The symptoms the doctors diagnosed him with are low muscle tone, aspiration, cherry red dot in his retina, different rib and vertebrae symmetry, and developmental delays. Out of all of his symptoms, the ones that affect him the most are eating and low muscle tone. Having low muscle tone, he cannot sit, roll over, or crawl on his own. So his life most of the time consists of laying down, being held, or sitting with support. His eating is the most significant symptom because some days he can eat a good amount and other days he struggles to eat. This is very stressful for us as parents because we don't want to see him struggle with nutrition and we worry about him needing to be on a feeding tube at any point. On his worst days, he is fussy, frustrated, and acts like he is in pain. On his best days, he is happy, squeaky, and not in pain. It affects the way he sleeps and interacts with people. When he naps, sometimes he wakes up screaming and crying. He also startles very easy, which wakes him up. His interactions with people are not of a normal baby. He listens, but he has nystagmus, so his eyes aren't able to focus. He occasionally smiles, coos, and laughs in response to some interactions. He is very sweet and likes to cuddle. Daxton is developmentally delayed, so he doesn't pick up new skills, which makes it difficult for him to gain new abilities in order to eventually be self-sufficient. This is something we are coping with to the best of our ability. It isn't easy, but as parents, we make it work to give our children the most love and the best life for this condition that we can. As a mother, I feel like I'm not able to work outside of the home and give him the life that he needs. He has complex needs, and that I feel would not be met in a daycare. There are activities that we cannot participate in, such as hiking and swimming. It is even difficult to do simple tasks like going to the grocery store. Outings in general are harder than normal, mostly because he is attached to oxygen and we must carry a 10-pound tank around with us. Daxton is on oxygen from past aspiration. We actually didn't even know he was aspirating on bottles until he was admitted into the hospital. We are new parents, so we didn't even know what symptoms to look for or to go off of other than what his oxygen was when he was hooked up to his Owlet monitor. The Owlet monitor is a device that was made to track your baby's heart rate and oxygen rate while your baby is sleeping. Daxton's oxygen on the Owlet monitor while sleeping would drop to low 80s multiple times a night. I made an appointment later that day to see his pediatrician, where sure enough, his oxygen was reading below what it should have been. When we are at home, he is hooked up to an oxygen concentrator, which means he has roughly 20 feet to move around in. This prohibits me from moving around the entire house as needed very easily. I think what frustrates me the most about this disease is that the condition of Daxton's life is different than that of a normal baby. Every time we go to visit family, we need to pack not only the normal baby items, but also pre-made bottles and make sure he has enough oxygen to last while we are gone. I have only left Daxton once or twice with my mother while I ran errands. I don't feel comfortable leaving him, and also bums me out because most parents can drop their kids off to their grandparents for a sleepover, and I'm not able to do that. If there was anything that I wish we could do the most, it would be to travel to see other family members or get out in nature to hike. My biggest fear is that Daxton will not have a long life and that in the meantime, he will lose all of the abilities he has now. Basic abilities like eating and motor skills. I worry about everything that can happen with the disease, including seizures and loss of all movement.
Hi, my name is Ben Sendrey, and I would like to share with you our GM1 story. Well, where to begin? I live in a small village in Hungary with my wife Esther and our 2-year-old daughter Biborka, who was diagnosed with GM1 type 1 early infantile at the age of 7 months. But let's start at the beginning. Biborka was born on the 11th of July in 2020. This day was the best day in our life. She was so cute, everything went well, nothing bad happened, so she could come home with us after a few days. Although she was diagnosed with clubfoot, everybody was telling that she would grow out of it. Let's just do some exercises. She was a very calm baby. She did not cry much. She slept a lot. She had a little edema on her eyes, but they said it is not a big problem. We went to the hearing test with her, but she did not pass it until after the 4th try. Maybe this was the first sign of the disease, that she is not hearing well, but at that time no one noticed. Days and weeks passed, and we noticed that Biborka's reaction to the outside world was not like children her age. She didn't pay attention, didn't react to sounds, and couldn't lift her head up. Everyone told us that we shouldn't worry about it too much, because every single baby's development is different. We went to a physiotherapy called Davey method, where our physiotherapist diagnosed her with a strong hypotonia, but she said it can be treated. But sadly, the results showed 2 specific GLB1 gene mutations, and at the age of 7 months old, Biborka got her diagnosis. At this age, she was well and stable. She slowly improved, she started to move her head better, she played a lot, we had so much fun together. We think that the Davey physiotherapy was helping her a lot, and we did this 3 times a week. Biborka's development plateaued at the age of 1. And then she started to regress. At first we noticed that she did not move her hands and legs that much. She was not following the pictures we showed her as she did before. Also, she had more problems with feeding. It was a really slow regression, and we realized that this is not going to stop. At the age of 15 months, she caught an infection, and we needed to go to the hospital with her. And this is when the GM1 really started to show itself. She was very ill. She was intubated for weeks. She beat 3 pneumonias, and she had her G-tube surgery as well, because it was hard for her to swallow. After a very long 2 months in the hospital, she made it through, and she could come home with us. We needed to learn how to care for her, how to use the G-tube, how to dose her medicines, how to move her from one place to another, and so on. She needs 24-hour care every single day of the week. It is not easy, but we love her so much she could make us the happiest person in the world with a single smile. You know, living in this situation, living with GM1 is really hard. It affects your whole life, your emotional state, your marriage, your work, everything. Every day is different. Sometimes we are so depressed that we don't want to meet anyone, but sometimes there are happy days. Mostly when Biborka is well, when she smiles, or when nothing bad happens. Those are the good days. But yes, sometimes it is really frustrating. Sometimes she has breathing issues and seizures, or just cries because of pain. As a parent, this is the worst feeling ever, that sometimes you just can't do anything to help her. At the moment, Biborka is 2 years old. She slowly regresses. We created a foundation for her, and thanks to the good willing people's donations, we could buy her professional equipment like a special bed, bathtub, pram, proper monitoring system to see her blood oxygen level, heart rate, and her wall status, and other useful kits to improve her life. Sadly, we cannot move her anywhere far from home, maximum in the backyard, because there is a chance for a bad thing to happen every single day. We don't know what the next day or the next hour brings. We don't know how much time we still have with our daughter, but we want to use every moment with her. Live for today is what we follow. Our greatest fear is that she will have more pain as the disease progresses, and we will lose her too soon. But at the moment she is stable, and that is all that matters. We really hope that there will be a cure in the future to this horrible disease, and no other family needs to suffer. There must be a solution. Thank you very much.
My name is Megan, and this is my daughter Marley's story. Hurting, but still hoping. Hoping does not mean that we ignore reality. Hoping means we acknowledge reality, and yet in the very same breath, we acknowledge the promises of a future without pain or suffering. Our reality is that our sweet daughter, Marley, has a horrible neurodegenerative disease called GM1, Gangliosidosis, type 2. Marley's story begins on a cool March 9th afternoon in 2017, when we welcomed her into our lives after a quick labor and delivery. The following days were filled with coos, giggles, and smiles. Our home was filled with joy. Around 3 months, we noticed a bump on Marley's back. Around 18 months, family and friends began to comment on how Marley was a late bloomer, taking her time walking and talking. We knew something was happening to our daughter, but no one could give us an answer until December 17th, 2019. The call that steals your breath, robs your dreams, and sends you into the deepest, darkest valley. The answer, the brain MRI was abnormal, and your sweet, innocent daughter has a rare genetic brain disease called GM1 gangliosidosis. The answer, your daughter will not live long. At this point, Marley was still walking, sitting up, smiling, and babbling. How could we end up at her funeral? Sadly, the reality was she had already began showing signs of regression in mobility and communication. The summer of 2020 was the last time Marley walked independently. The loss of mobility affected Marley both physically and mentally. Playing with her sister and friends now looked different, and exploring her world became a lot smaller. She's sad, confused, and frustrated as to why she cannot do what she used to. She is stuck, waiting for someone to pick her up, waiting for help, waiting. In the waiting, she cannot communicate her needs, her wants, or her dreams. We can only guess. She attempts to use an eye gaze system and communication buttons to give her a voice. But the reality is, we will never hear our child's beautiful voice, so we must speak for her. The loss of mobility and communication is horrifying because it means that the disease is ever moving and not relenting. The loss of skills means that Marley will be less active and rely more on equipment. She will continue to lose more and more skills until ultimately her life. While other parents are taking their children to soccer practice and dance, we are taking Marley to outpatient therapies, hippotherapy, and working tirelessly to keep her strong to fight GM1. Marley has been enrolled in a special education program where she is able to use a gait trainer and an adaptive tricycle. This has given Marley a sense of independency and normalcy. We can see the pride on her face when she's walking and pedaling her bike. She feels strong and proud. As Marley continues to fight the loss of skills, there is one symptom that Marley is even more defenseless to: seizures. Seizures have been one of the most debilitating milestones. As her body enters into a seizure, her arms and legs stiffen. Her face becomes beet red. Sheer panic comes over her body. The worst part is she stops breathing. And so we wait and pray that she will breathe again. Her little body is tired, in pain, and her mind is confused as to what just happened. All we can do is hold our fragile child. Recently, Marley has been having severe pain that lasts for 12 hours. She loses her voice from the intensity of screaming. She twists, turns, and stiffens as the pain consumes her entire body. Nothing will console her. All we can do is watch her cry out with no rescue in sight. In these moments, it feels like the pain will never end. She is hurting. The hope is fading. We wake up never knowing what the day will bring. The reality is that GM1 is a terrible, non-relenting disease that will try to steal everything from our daughter. Marley still has hope that someday she will walk, run, talk, and sing. That day may not be on earth, but we take comfort in knowing that someday she will have a future without pain or suffering. Psalm 27 reminds us, remain confident of this. I will see the goodness of the Lord in the land of the living. Wait for the Lord. Be strong and take heart. Hurting, but still hoping. Marley's hope is that someday soon there will be a treatment. Better yet, a cure for all children with GM1 gangliosidosis.
My name is Kylie, and my husband Kyle and I have 4 daughters. Our 2 oldest daughters were diagnosed with GM1, the juvenile form of the disease, about 2.5 years ago. Kinley, our 9-year-old, is very compassionate, social, and silly. She's always wanted to be a doctor, perhaps because she spent so much time with them. Kennedy is our 6-year-old and is undisputedly the princess of the family. You can find her dancing and singing to her favorite Disney songs. We first started noticing delays with Kinley's development when she was around 3 years old. We could tell she had speech delays, and she was also very clumsy, especially for a kid whose parents were extremely athletic. By age 4, we knew something was definitely wrong. She wasn't just having delays. It was like one day she could do things and the next day she couldn't. In addition to speech therapy, we started occupational therapy and we began seeking a diagnosis. We went from specialist to specialist for evaluations. Then Kennedy started showing similar signs of the same speech delays when she turned 3, and we suspected there was something genetic at play. It took us over 2 years to find a diagnosis. Of the many symptoms of GM1 that the girls deal with on a daily basis, the 3 that stand out the most are communication, mobility, and cognition. Both of our girls are very difficult to understand verbally, especially when the context of their discussion is unknown. They love to come home from school to tell us about their day, but oftentimes we're unable to understand what they're trying to tell us. Simple things like telling us their stomach hurts or they have a headache is nearly impossible for them to communicate. It's obvious that communication and speech is going to be the first of their major abilities that they will lose. Mobility-wise, the girls can still walk and run unassisted, though it doesn't come without a lot of bumps, bruises, blood, and tears. Falls are common and scary at times. When we go to new playgrounds, they want so badly to be able to climb and play like normal kids, but are not able to. They crawl or they scream, "Help me," when trying to navigate areas of the playground that even our unaffected 2-year-old can do independently. While Kinley was once able to read words, write her name, and even do math, academics are no longer a priority for our girls. Instead, we're more concerned about them wandering off or running into the street without looking for cars. Things that most parents worry about less and less as their children get older are things that we worry about more and more. Kennedy finished kindergarten last year, and while her symptoms are still in their infancy, she has started to realize that she's unable to do a lot of the things her classmates can. She cannot write, read, or hold her pencil. She cannot even put her jacket and shoes on independently. This leads to confusion, frustration, and anxiety for both the girls and us. Just as we learn to live with the current symptoms, they regress further. The future is an extremely scary prospect. We know they could live to be in their teens, 20s, or perhaps even 30s. We don't know, however, what their quality of life will be at any point. Will they be able to walk? Will they be able to talk? Will they even know who we are? And honestly, the scariest thing for us as parents is whether or not we will know when they've regressed to the point where medical intervention perhaps isn't in their best interest. One of the most frustrating aspects of juvenile GM1 is that it doesn't just limit their future, but it robs them of their past abilities as well. Explaining to a child why they're not able to do things that they were once able to do is heartbreakingly impossible. Comforting them, even though they can't tell you that they're upset because their friends can do things that they cannot. The simplest things that used to make us extremely happy, like hanging out with our friends and family, oftentimes can be emotionally difficult now. Seeing kids who are typical can really make you realize how far gone your child is. And though you're still so happy that they're here with you, things like celebrating the girls' birthdays is bittersweet because you find yourself mourning the past, incredibly grateful for the day, but so scared and nervous for what the future holds. To pour salt on the wound, a diagnosis of GM1 also comes with the reality that there's no approved cure, no approved treatment, and really no plan of action for caring for them. And for us, that's just unacceptable. We know that while there is no treatment and no cure yet, there is hope. Hope for Kinley and Kennedy, and hope for all of these brave children living with GM1.
Wow, Thank you so much, Kylie, for sharing you and your family's journey, and really to all of our panelists for being so brave to be the first to share today and help us understand so much of what it is to live with GM1 and what that looks like. We're now at our part of today's meeting, our first opportunity now to broaden the discussion and open it up to all of our families who are in the audience today to hear your experiences of what it is to live with GM1. If you would like to share some of the symptoms and health effects that your loved ones have been going through, please call in. You can dial in now or any point during the program at 1-703-844-3231. Again, that number, you can dial in at 1-703-844-3231. We'll get you into the queue and we'll be able to bring you into the conversation shortly thereafter. But to get us all thinking about these topics and to understand the experiences of our audience, we're going to first start with a polling question. So for those of you who were with us before, you can just go back to that same webpage. If you've joined us, you can go to www.pollev.com/GM1PFDD. You can do this on your phone. You could open up a new tab on your browser, go to pollev.com/GM1PFDD. So here we want to know which of the following GM1 related health concerns does the affected individual that you care for have or that they've had in the past? And here you can select all that apply. So the options are A, impaired mobility or loss of mobility, B, seizures, C, breathing difficulties, D, communication issues, E, muscle weakness or hypotonia, F, muscle stiffness, G, cognitive impairment and intellectual disabilities, H, various different visual issues, I, bowel or bladder issues, J, scoliosis and or hip issues, K, impaired fine motor skills, L, sleep difficulties, M, anxiety or other psychological problems, or N, some other symptom or health concern that your loved one has that is not listed in the set of response options. Again, we want you to select all that apply to your loved one living with GM1. So we'll give a few more moments here to get, I see results are still trickling in. What is immediately striking to me is just how much representation we have across all of these different response options. This is our first polling question today where our respondents could select more than one option. So I want to be clear, the percentages that you're seeing are not the percentage of people that selected any one option, it's the percentage of total responses. So for these types of questions, the best thing to do is think of these bars as kind of relative ranking of the different response options. So some of the most common health concerns that are experienced or have been experienced by those represented today include the impaired mobility or loss of mobility, communication issues, cognitive impairment, intellectual disabilities, and impaired fine motor skills. That is followed very closely behind with muscle weakness and muscle stiffness, as well as bowel and bladder issues and sleep difficulties. But again, every single thing here has a good deal of representation and experience, including quite a few other things. So we want to hear about maybe some of those things that aren't the most commonly experienced, or maybe it's something that's common that we just don't have listed here. We obviously, there's so much for us to explore in this session. But to help us, again, kind of further think about this, we're going to go to our next polling question. So here, you'll notice it's the same response options, but unlike before where we wanted to know everything that was experienced, here we want you to select the top 3 most troublesome of those GM1-related health concerns that your loved one either has currently or has ever had. So thinking about all of those different experiences that were just shared, which of those are, you can select up to the top 3 that represent the most troublesome of those health concerns. And again, it's the same response options as last time. I promise that these questions would get more difficult over time, and I'm sure just seeing from the last question how large, how, far to the right we saw all those bars extending, knowing that so many experience so many of these different health concerns, to try to narrow it down to the 3 that are the most troublesome will be a challenge.
Yeah, what's interesting is the cherry red spot is in the literature a lot, but people do have it, but it is not as common as I think the literature makes it seem.
So we saw that, while there are a number of visual issues, it was not one of the top most common experiences on the previous question. Here we're not seeing that visual issues are being reported as a top 3 most troublesome symptom. But what is interesting is everything else other than visual issues is a top 3 issue for at least some number of people. Although it appears that impaired mobility and loss of mobility is the most frequently selected kind of top 3 most troublesome concern, with perhaps after that communication issues, followed by cognitive impairment and intellectual disabilities being the second and third. Maybe the next tier down we have is seizures, breathing difficulties, muscle weakness, and sleep difficulties. But again, as you were thinking about these and making these selections, the most important thing is to think about why. Why did you pick one over another? What came to your mind and made you make that selection? And we hope that you'll call in or write in with a comment to help explain your selections. That will be really helpful for us today. So
Another thing with bowel and bladder issues, people also have difficulty with motility, so that could kind of be covered there a little.
Absolutely. So thank you for participating in these polling questions. Again, we'll be coming to different polling questions throughout both this morning and then our afternoon sessions. At this point, I'd like to welcome a group of people who are participating via Zoom, our Zoom panel discussants, who are going to be helping us kick off these different discussions that we'll be having. Continue to call in and write in. We'll get to you shortly. But at this point, I'd like to maybe start with Stephanie. Stephanie, as you were maybe looking at that polling question, thinking about the wide range of different GM1 symptoms and health concerns, what stood out as maybe most troublesome, and what informed those selections? I'm sorry, I'm not hearing you, Stephanie. I still cannot hear you, so maybe we'll circle back to you in a moment. I'd like to maybe go to Lindy then on that same question of thinking of the different symptoms and health effects. What stands out as most troublesome?
Well, let me introduce myself. My name is Lindy. I have a beautiful son. His name is Armand. At around the age of 2, he was diagnosed with GM1 type 2A. Obviously, it was a very, very incredible, difficult diagnosis to hear. And I just want to show you a picture of him just so you can kind of put a face to the name there. I think some of the things that we deal with that is so incredibly difficult with the GM1 is lack of communication. That is one of the toughest things to deal with because these kiddos go through so much pain. But we as parents and caregivers have to kind of go through a list of things that, start with the smallest thing that could be causing discomfort. And we have to figure this all out on our own. Since these kiddos, a lot of them lose their communication. Armand could walk and talk like a typical kiddo, and by the age of 4, he's now basically like a 3-month-old when he's nearly 14 now. And the lack of mobility, that's incredibly difficult. That also falls on our shoulders as well.
Sure. So, Lindy, one thing that struck me from what you were sharing is like this, now, given the difficulty in communicating, it's almost really like this, deductive activity that you as a parent have to go through. Can you maybe share an experience or an example of a time that you can think where, there was an important need that was trying to be communicated, and what that deduction kind of looked like?
Sure. So very recently, Armand actually had a broken femur. And these kiddos, because they go through pain every single day, their pain tolerance is incredibly high. And I knew something was bothering Armand, but I couldn't put my finger on what was going on. So of course you look, are there potential pressure sores? You check their mouth to see if there's issues with dental issues, teething, issues with their gums. You readjust them, and during an adjustment,
Mm-hmm.
Armand started to flinch when I would touch his leg. And then we took him in, and sure enough, he had a fractured femur right above his knee.
Wow.
So incredibly difficult. And a fractured femur to a typical person, it would be excruciating.
Yes.
And he only flinched. So, we live very, very difficult lives, caregivers, but the kiddos, it's so difficult for them.
Yeah, no, that's a pretty powerful example, to imagine not being able to, share the pain and describe the pain, to a parent, or, express the pain, in a way that any of us would in that type of situation. Can you talked about, the regression in communication skills. Was there something early on that was like one of the first things that you noticed that clued you in to that?
Yeah, absolutely. I noticed, so Armand, this kid was a go-getter. And I know this is going to sound crazy, but this kiddo was walking around furniture at 7 months old. He couldn't walk independently, but he was definitely walking around furniture as long as he, was supported at 7 months. So by 18 months, this kid should have been running marathons, but he would only take 10 or 15 steps and fall down. And I thought, wow, that's really strange. So at his 18-month checkup, I discussed it with his pediatrician. And she agreed something definitely wasn't quite right. In addition, he only spoke about 5 words.
Okay.
Yeah. And so he was never really able to put sentences together. And it really was just, a handful of words. And that also was very concerning to me. Although he could read and pick out words in a book, he couldn't verbalize that. And then from there is when we started down the road of getting a diagnosis.
Right. And in terms of those words and ability to read, is there any ability to read or speak any words now currently? If not, it sounds like there's not. I thought that's what you had mentioned earlier. How long did it take, and what did that look like in terms of losing the reading and speaking abilities?
Very. That was very difficult. Although I did hear him say mommy. He kind of called everyone mommy. Probably because when he was born, I'm like, say mama, mama, mommy. I was very on top of that. So then he just ended up calling everyone mommy. But I think things that parents with typical children don't realize is the things that we as GM1 parents don't get to hear. I've never ever heard my son say, mommy, I love you. So that is incredibly difficult. And just overall communication, just being able to let me know if he needs something, or is in pain or scared or sad or excited or happy. By the time Armand was 4, pretty much everything, he had regressed really truly to about a 3-month-old. So it's very difficult. He's definitely 100% dependent upon me. Yeah. And I just don't feel this is not a life for a nearly 14-year-old.
Right.
And I'm just hoping and praying that if there is not a cure within my son's lifetime, I hope that everything that we have done as parents, that was what we were put here for, is to help other kids and families to overcome, conquer, and have a cure for this disease, so other families and kids do not have to go through this.
Absolutely, Lindy. Well, thank you so much for sharing, and I know even just your this is only one day of you and your family's contributions, but I know today your participation is going to help advance that cause too. So I'd like to bring Jenny into the conversation, this same topic, reflecting on the wide range of impacts from GM1. What top 1 or 2 of those are most troublesome?
Yes, thank you, James. As James said, my name is Jenny. I live in the North Dallas area in Texas with my family. I have an almost 11-year-old neurotypical son who is wonderful big brother to his 8.5-year-old sister, Clara, who has type 2A late infantile GM1. Interestingly, with these selections, I chose other actually for my most concerning symptom and health effect on my daughter, and that's really her managing of her secretions. And so, and that probably is a subset of the hypotonia, but we have increasingly seen that she will she can't sit up on her own. She's very, as Lindy was saying, like kind of like a 6-month-old, but she has a hard time and chokes on her secretions.
And can you maybe describe a little bit, paint a picture for us of these secretions? What is is this something that's kind of ever present throughout the day, all day, every day? What does that kind of look like for her?
Sure. So typically we have her in a chair it's called a pea pod, and it has a slight recline to it, or a significant recline to it, but it happens just automatically. No, there's no warning. It's just all of a sudden she's gagging on her saliva and she's not able to clear it. So we have to go over and sit her up and pat her on the back, and it happens for no specific reason. There's no reason that it's associated with. And it will happen to her at night as well while she's laying down. And so we'll have to go in there and do the same. And ultimately, my main concern is not only her comfort, but obviously aspirating on that saliva and obviously getting pneumonia and the effects of that.
Yeah, and is from day to day, is this a pretty consistent number of these kind of choking events that happen? Does it vary much? And just generally, how many times a day would you say there's one of those types of events?
Well, when it first started, it was just here or there, just like with all of these symptoms for GM1. It's one of those things where is it a one-time thing? And it just happened and a couple times here or there. And that was probably about 6 to 9 months ago. And now we're at a point where we've gradually gotten to the point where we are seeing her do this at least 6 to 8 times a day, I would say. And it's definitely concerning and on top of our concern.
Wow, yeah. And, you talked a little bit about the difference over time. Can you maybe describe also how you are able to kind of recognize this? Is it something that's very obvious, or sometimes do you maybe realize that this has been going on for a number of moments, minutes, just for someone that doesn't have this image or picture of what this looks like? Help describe that a little bit.
In regards to when she's actually choking, it usually goes on. It depends on how quickly we can get to her, because sometimes it takes a little long to recover from it, and other times maybe like sometimes it'll take like a couple minutes for her to actually be able to clear her, and we're usually holding her up, which she's has hypotonia and hypertonia, so she's very stiff arms but also very weak, so you have to completely support her, and she's 8.5. And so it's usually somewhere between can be as quick as 30 seconds to about like 2 to 3 minutes, where we're trying to help her clear it.
I see. Well, Jenny, I want to thank you for sharing, but also for sharing something that was one of those others. It's so, we do want to hear about this, range and diversity of experiences, and to know that there's some things that are, so troublesome and worrisome every day, all day, it sounds like, day and night. So I appreciate you sharing that. I do see that we have a phone caller. We have Matt, who wants to share the experiences of Marley, who is living with GM1 type 2. So I'd like to welcome Matt to the program. Matt, are you with us? I'd like to welcome Matt to the program.
Hi.
Oh.
Hello.
Hi,
Yep,
Matt. I
I'm
can
here.
hear you
How
now.
are you? Yes, sir. Yeah, thanks for having me on. So, as you said, I'm the proud father of Marley. She is 5 years old. She was diagnosed with GM1 type 2A just shy of her 3rd birthday. So obviously that was a major shock to us, and it's taken obviously a couple years to just be able to process that. And so, yeah, I'm calling in just to share our experiences. I just took the poll with regarding the symptoms, and I think I had selected loss of mobility, just general, regression of skills and loss of skills, communication issues, and seizures. I think, thanks to the previous callers, they touched on a lot of those things, and really summarized a lot of the issues these beautiful kids go through. I think for Marley, I'd probably think of loss of mobility first, because, early on in her life, she was a little late developing, but she was able to walk a bit on her own, and she could move around and cruise around the house, from her own furniture. And her fine motor skills were better. Like, she could, pick things up and, read through a book on her own, look through a book. But gradually those skills started to regress. And then really out of the blue, like it was June of 2020, I can distinctly remember just over a course of a couple days, you noticed like when she wouldn't walk anymore. She would just stand there. And so we started to get concerned. And then over the course of a few days, she just stopped walking just abruptly. And now she would she'd be able to walk pretty well with assistance while holding her hands. And now to the point where it's really difficult for her to even be able to walk, with us holding her hands, my wife and I, Megan. So she walks in a pacer, with, help from equipment. And a lot of times she likes to sit on the floor, so she sits on her knees, but even now her balance and her core strength is limiting her ability to be able to do that.
Right.
So all that to say is, like, Marley has gone through losing skills, and it's awful to see that and live that every day, and to the point, like, it's so hard as a parent to look back. For me, I can barely ever go back and look at pictures or videos from, a couple years ago, just because I'll see what Marley used to be able to do, and now that she can't. And so there's it's just a profound sadness, to look at those things and kind of remember an innocent life, a time before, we knew what her diagnosis was. And so that's really difficult. And of course, Marley's just amazing. All these kids, I don't know them all, but I can speak for Marley. They're incredibly resilient. I think I've said Marley is the strongest person I've ever known or will ever know. Mm-hmm. And she inspires me daily with just how strong she is. Yeah. I think communication issues as well. As a previous caller, I think it was Lindsay, said, just never being able to hear your child say that they love you. It is really difficult. I think Marley, she was able to say a few words when she was younger. I don't know if she's ever really said dad. Maybe I can't really recall, but as somebody else said, the pain, Marley will have days where she will be crying and screaming in pain for 8, 10, 12 hours with very few breaks in between. And she can't tell us what's wrong. So you have to guess, as somebody else said, you're just going through your mind, what could this possibly be? And you're running through the whole gamut of, possibilities in your head, going to the ER. And every single time, you go to the ER and it's a guess to them, most of them. Oh, I think she may have an ear infection. They don't know. And so really you're left with, well, this is just some weird neurological pain or, issue that she's going through that we probably won't even be able to get down to the bottom of, So there's those very difficult days where they're just in pain. They can't verbalize it.
Matt, how often would you say those days? Is that a couple times a year, once a month, once a week?
Well, really, those days just started earlier this year. I'd say in March of 2022, mm-hmm. And those were happening about once or twice a month. Okay. Usually it was weird. It was always late in the month. It was March 20th, and then April 25th is always late in the month. So to the point where we're looking up, does this have to do with the lunar, the moon, and we're just, you go through all this stuff, you're thinking how to figure out. So that was happening about every month, and then we've had some great help from palliative care and other doctors who have helped get Marley on some medications that have really seemed to give her some relief. And so those days are few and far between now, which is great. But yeah, still she'll just once in a while she'll just have a day where she's just having a rough day, and we just kind of have to just endure and get through it. And but they're tough. And then there's other things like Marley not being able to speak. It's hard to know if I can teach her things, or if she can't ask me questions. There's a picture recently. Marley started kindergarten, and they had a hot air balloon land near her school, and her teacher sent us a picture of Marley sitting there looking at this hot air balloon. And I was looking at it, I just got choked up because it's she can't ask me Daddy, what is that? How does it work? She's just left to just kind of ponder it on her own and can't ask me questions, and that's really tough as a parent.
Can't imagine.
Yeah, so those are some of the difficulties we face.
Well, Matt, I really appreciate you calling in and covering a number of these, things that were, I think, a top symptom for so many people. The mobility, of course, the communication we've heard a little bit about, but really helping us understand Marley's experiences with those have been so informative. So thank you so much. I do see that we have another phone caller, Ruth from San Diego, who also wants to share some experiences of her daughter Tiffany and the different health concerns related to GM1. So Ruth, I'd like to welcome you to the program. Are you with us?
Yes, hello.
Hi, welcome.
Can you hear me?
Yes, we can.
Thank you. Yes, Well, I just wanted to share, and I think most of the parents have already shared what my feelings are. Pretty much every parent that I've heard exactly explains what what we as parents go through, looking at our children going through so much pain and regression, and not being able to understand what's going on with them because the doctors have no clue, and just trying to navigate without any medical knowledge and any real knowledge how to help our children, you know, and just guessing and just trying to give them some relief.
Right.
And yeah.
Yeah. Well, Ruth, one thing that I saw noted about Tiffany's experience was that she has rigidity, and that impacts her daily life quite a bit. Would you mind sharing a little bit about that?
Yes, that's what I wanted to mention, that she is now 20 years old, and I am beyond grateful for having her all these years. But now, thanks to the Botox shots, she's getting a little bit of relief on her right leg and is able to walk in her gait trainer. But again, you know, to me, finding a cure or some way of stopping the spasticity, the rigidity, would be great, because it's so hard to get her dressed and to get her to, you know, raise her arms or give me your foot, or, you know, and even to feed her now, I can see that she's having trouble moving her tongue from side to side or being able to chew the food. I have to cut it so small and find foods that she's able to actually swallow. And with the fear of, you know, one day she will have to have a G-tube. And to me, you know, having this hope of the FDA approving these meds and arresting the disease and helping us parents here and all over the world who go through so much to try to keep these kids, you know, healthy and taken care of, and give them a better quality of life. I mean, this is great. You know, what all the parents have shared is exactly my feelings. Like I said, these kids are so resilient and teach us so much every day to be strong, to be happy in spite of all their trials and pain. And you know, just like all the parents, one thing that I think it gets to me the most is the fact that they're not able, my daughter's not able to tell me when she's in pain, when she is hurting, and I just have to guess, and you know, because she has periods, and when she has cramps, and, you know, I can just see her face, and just guessing, you know, what's going on in her body. It's just so much hope that these meds were approved to help all these kids.
Yeah, well, thank you, Ruth. You know, it's so important to hear, you know, to help advance, you know, a pipeline of future therapies, to know what is impacting people the most. And so thank you so much for sharing some of Tiffany's experiences. I do want to circle back to our Zoom panel. Stephanie, I think we've got things worked out. We can bring you back into this discussion, you know, of you know, the things that are most troublesome, of the direct symptoms and health effects of GM1. Would love to have you weigh in on that topic.
Yeah, hopefully you can hear me this time.
Yes, we can hear you.
Hi, I'm Stephanie. I'm from Virginia, and my son's name is Aiden. He is a year and a half old, and he has type 2A, so late infantile onset. And for us, I think that the most difficult symptom has been the hypotonia because it really underpins a lot of the other issues that we have with him, including sleep difficulties. It causes him to have obstructive sleep apnea. So he wakes up all the time. He's never gotten good restful sleep. And he has significant feeding issues because he just doesn't have the tone in his mouth muscles and his ability to swallow. And so we are constantly afraid of him choking on his food. There was a couple months where we couldn't give him any solid foods whatsoever after he's just like such a little foodie. And so for him, the loss of being able to eat, like oysters and filet mignon, it was just a big change in his quality of life, and being afraid of aspirating on his bottles. He was constantly choking on it, even from the second day of life. It was actually the first symptom that, looking back now, the feeding difficulties has always been an issue.
Yeah. And that's, I think we've, heard a little bit about feeding difficulties, but it's interesting to hear about it from a hypotonia perspective. Were the sleep difficulties also always present? You mentioned the feeding difficulties, but you mentioned the sleep apnea and sleep difficulties. Has that also been present, or is that something that's kind of set on a little bit later?
Yeah, so that's actually also related to the hypotonia because he had really horrible reflux because the weak muscles also resulted in really bad reflux. And so he would just wake up screaming in pain. And that's been the case pretty much his entire life. Eventually it got better and then it got worse again. The central sleep apnea set in where his brain stopped communicating to remind him to breathe. And then the obstructive sleep apnea set in. And so it's like I felt like we fixed one thing with the reflux, and then the next, set of decline really just made that all worse again.
Right. And Stephanie, you also mentioned that there's a recent or somewhat recent period of time where wasn't able to eat solid foods or food, the types of foods that he would normally want to eat. Are there? So that makes me think that there must be worse periods. Is this like kind of day to day, things are highly variable, or is it really like there's a couple weeks or months at a time that things are better or worse?
So he went through a very significant regression after we all got COVID. It caused a very fast regression in his skills. He used to be able to bring food to his mouth and eat and swallow and handle solids. And then he couldn't even handle basically his bottles. The only reason it changed, it would have continued to decline. We were part of a clinical trial for one of the therapies, and that's the only reason that things have gotten better, honestly. So otherwise, it was very just steady decline where things were just getting worse and worse.
Sure. Yeah, that's, obviously, you mentioned there was at one period of kind of a pretty rapid decline, but it's been otherwise pretty gradual, over time. Are there, does that, I'm just curious, since we haven't talked a lot about issues with sleep, does that at all then translate to quality of life during the day, other maybe symptoms during the day? Do you notice any types of relationship on those periods where sleep is worse, that other aspects of life are worse?
Absolutely. I mean, obviously, as a caregiver, that's one side of it. But I think for him, I noticed the pain is worse. Obviously, you need your sleep to be able to help repair your body. And so if he's not sleeping well, I notice he's in a lot more pain, and that's really difficult. And then also, I noticed that he has a harder time. He will lose skills more quickly when he's not sleeping well as well. So that's really difficult to watch because one day he's doing something and then you don't realize that's the last time you'll ever see him do that, and you can't get it back.
What kind of skills are you referring to there, Stephanie?
So, I mean, in the period that he regressed, he went from, he was cruising on furniture and taking assisted steps and crawling and feeding himself. And then over the span of a couple of months, he was entirely reliant on bottles to eat. He could barely sit up on his own. He can't grab anything. His hands just stayed stiff and unable to open or close, lost almost all of his expressive communication skills.
Right.
And just, it was pretty much everything that, you check off. He went from like a 12-month developmentally to about 4.5 months.
Okay. Yeah. So really a wide range of skills there.
Yeah.
Well, thank you so much, Stephanie. I do recognize that a number of you have been writing in with comments, and so I really appreciate those of you who are tuned in and submitting comments in that little comment form that we have. Christine, I know you've been checking on those. What are we seeing?
Oh, I wanted to read this comment from Manuel in Malta because Malta has a founder effect for GM1. So he is talking about his son. The most significant impact on Andrea in his initial months was the ability to maintain a steady position. So he lost that. And during the course of time, he had problems with breathing normally and the ability to swallow. So I feel like that's a very common theme, the mouth, speech, swallowing, secretions, all of that with the mouth. And then we do have a Karen from the UK whose daughter has type 3 GM1, which is really, really rare. And she says that her daughter has a complete loss of mobility and 24/7 pain. So pain is a major aspect of this disease as well. And we have Sal from Portugal. So the disease is all over the world and it's not isolated to any specific population. So her daughter, the symptoms started at age 7 and now at age 14, she's regressed a lot. Leonore developed very well in early childhood as a baby, but it wasn't until age 7 that she started to sit and move differently on the floor. She fell a lot. They thought it could be some sort of inner ear problem. At age 8, she began to stutter and speak badly. She says, we went to the doctors, we did tests until the neuropediatrician asked for genetic tests. At age 9, we knew the diagnosis.
Yeah. Well, I want to thank everybody who has been writing in. We're going to continue to share those throughout the program, but no, even if we don't get to reading your specific quotes, or even, I know many of you are probably submitting more and we're just able to read a little bit of it, we will be looking at all of that and using that when we put together the Voice of the Patient summary report for this meeting. So I want to broaden the discussion. We've been really focusing on the direct symptoms and health concerns of GM1. We've already started to hit on this, but I want to broaden this to bring in the idea of how that impacts activities in daily life and the things that your loved ones with GM1 are able to do. And so we're going to go to a polling question to kind of kick us off on this added topic. So go ahead and pull out your phones, go to that browser, open that tab that you might have open, go to www.polev.com/GM1PFDD. And here we want to know what specific activities of daily life that are important to you and your loved one, are you or they not able to do or struggle to do as a result of GM1. And here we want you to select those top 3 kind of important activities that are limited or not possible. So the options are A, getting around and mobility, B, communicating needs or wants, C, socializing with peers and siblings, D, self-care, things like bathing and dressing, E, the ability to eat by mouth, F, the ability to travel or do things like family vacationing, G, participating in social engagement, events, sports, H, attending school or having a job, or I, some other activity of daily life that's important that your loved one is not able to do or struggles to do as a result of GM1. And again, we're asking here to select up to the top 3, of those important activities that are limited. We started to hear about some of these things already, but more from the perspective of the symptoms themselves. Here we want to kind of understand what this looks like in daily life and how that impacts what you can do in daily life.
And in our caregiver preferences study that we recently did, the communication, people would be satisfied with limited communication. It doesn't have to be, complete expressive verbal communication, like any form of clarity or any improvement over really not having very much communication at all would be wonderful.
Sure. Yeah, so we're seeing here that communicating is one of those, is the activity that is being reported most commonly as a top 3 important activity that's either limited or not possible, followed by getting around and mobility. I think we've started to kind of understand those trends from what people are already sharing, but we do want to hear more about that and what that looks like in daily life. However, we're seeing every other one of the options here in others' top 3. And so we want to know, is it one? Is it maybe multiple of these different symptoms and health effects that, for example, make self-care difficult, make travel difficult, make participating in different activities outside of the home difficult. So I'd like to encourage you to call in if you would like to share your experiences. That number is 1-703-844-3231. Again, you can call in, share your experiences of the impacts on activities in daily life at 1-703-844-3231. Of course, you can write in as well. But I want to circle back to our Zoom panel to get us started. And Cindy, maybe we can start with you. Thinking about activities that are important in daily life, what are some of the most significant ones that are difficult for you all?
Well, hi, I'm Cindy from Oklahoma, and our son has GM1. He has an unusual form of GM1. He has kind of a subset that shows juvenile onset, but also adult onset. So our story is a little bit different than other people's because our son did everything normally until he was about 5 years old. He talked, he walked, he ran, he learned to read. He was able to start school in a normal fashion. We had no idea anything was even going on. Everything looked typical for him. And then the onset for him was very slow. And so I think kind of what I have noticed doing this over the long term with him, just walking this path with him, he is 34 now, is just that our whole world that used to be really big just got smaller and smaller and smaller and smaller. I mean, you just start eliminating things from your life that your child is unable to do. And as you do that, your world gets tinier, your interaction with people gets tinier. People don't like to interact with children who have special needs because they're scary. They don't mean to be mean about it. They're just scared of it, or there's kind of that fear that, it's contagious or something when it's not. So I don't know, your world just narrows down, and every so often I just have to remind myself, now wait, we're just stuck here in our house doing nothing. Is there something we could do? What could we do what would it take for us to be able to do something outside of our circle?
Right.
And sometimes I can figure it out. It's hard. I mean, like traveling is unbelievably hard.
Yeah.
But we have attempted it on occasion, and we've had successes and we've had failures where it was a disaster. But every once in a while, I have to remind myself that we can't live in this tiny little bubble.
Right.
Ever, that we have to figure out ways to break out.
Right.
And so I just have to think that through and maybe just solve one problem at a time.
Right. Cindy, you raise really important points in terms of, the experiences of, limited, ability to kind of engage socially and outside of the house. And of course, certain specific activities like traveling, but just even generally the, kind of people not understanding, GM1 or, someone that's, like someone with GM1. And, I just wonder if you could maybe tell us a little bit about like the types of things that you as a family would do that you've stopped doing, whether that's, a community activity or something even maybe with other, extended family members or close friends? I mean, what are some of these things that now you talk about this really kind of small bubble? You know, can you maybe put that into perspective for us a little bit?
Well, sure. Accessibility issues are better in our world than they used to be, but they're not perfect. For example, our typical developing daughter played basketball, but it was very difficult for us to take our son to the basketball games because you couldn't get him up into the stands, obviously, because he utilizes a wheelchair, and there was no way to do that.
Wow.
And also, he's big. He's not a little child now. He's big. He's 34. He's the size of an adult. So you can't like pick him up and carry him somewhere. And if we put him right down on the sidelines, it was very scary for him because there was intense action going on the court. So we ended up having to figure out a way to attend her games individually. So we never got to go as a family.
Right.
So those are the kind of things that happen for a lot of families, I think.
Yeah, no, and that's I think a very helpful example, both showing the physical limitation, but also, you know, the one maybe way to get around that being sitting closer to the court. You know, there's, you know, it's difficult, you know, if it's with that action and, you know, that stimulus, you know, that's scary, and, you know, it's a whole nother aspect, you know, having to navigate. One other question I wanted to follow up with was, you know, you did talk about vacationing and travel. You know, was it accessibility that made that hard, or was there maybe obviously in addition to that other aspects of travel that, you know, when that didn't go so well, you know, what about GM1 made the travel difficult, or as you put it, at sometimes disastrous?
Well, our son still talks. He doesn't talk in the same way that he did when he was younger. He talked completely typical, normal when he was small. But as he lost the ability to talk, he also lost the ability to control the volume that he talks at. So when he does speak, it's very loud. And it can be sort of disruptive, and this is difficult on an airplane.
Sure.
It's a matter of trying to kind of balance out what your family is willing to tolerate in terms of the disapproval from other people on an airplane.
Right.
Like, are we willing to go through that so that and just be bold enough to let him speak at a very loud volume and have people give disapproving glances or even say something to us about him being so loud? Because there's no way to help him understand that he can't be loud. I mean, we can explain that to him, but I don't think that he fully can process that.
Right. Yeah. Well, thank you so much, Cindy. I want to bring Brittany into this discussion of these activities that are difficult or just not possible because of life with GM1. You know, as you're thinking about that, Brittany, you know, what stands out to you?
Yeah, hi, James. My name is Brittany, and I live in Alberta, Canada, with my husband and my two little boys. I have a 10-month-old son and a 2.5-year-old son. My 2.5-year-old son is Harrison, and he is diagnosed with type 2A GM1, late infantile onset.
Mm-hmm.
So the one that stood out to me the most was actually socializing with peers and siblings.
Okay.
Harrison has a 10-month-old brother who's now surpassing him in skills and abilities, which is difficult. And he also has a lot of friends and a lot of family. And so trying to take him to play with his cousins and help his cousins understand what's going on with Harrison is tough, and eventually having to explain to them that he might not be here someday, or he won't be here someday.
Mm-hmm.
You know, just typical 2.5-year-old things, going on play dates with friends. Those pretty much don't happen for us.
Right.
Because I'm worried he is wheelchair bound. He can't sit up or crawl or walk. He never actually learned to crawl or walk. So wondering if the house we're going to has room for his wheelchair, if the park we're going to has a comfortable place for him to lay, if the kids are going to talk to him, because he just kind of lays there. You know, he can't really interact with anybody. So that's really hard. And I have a 10-month-old son, so he's going to be going on play dates too. And I'm already worried about, am I going to be able to do that with him? Is he going to have a normal childhood, or am I always going to be worried about how we can accommodate Harrison?
Yeah.
Or am I going to have to leave Harrison out of those things? And I don't want to do that. And so right now it's very hard for me to go anywhere with them. I can't push a wheelchair and push a cart and hold a baby and wipe drool off Harrison's face and talk to people that look at him and say, oh, is he asleep? Or, oh, he's so cute. You know, it's a lot. It's very, very difficult. And so kind of like what Cindy was saying, our world has gotten really small, really fast. And it's just not what I imagined being a new mom would be. And during COVID too, like that's made it even more difficult because you're scared to take them anywhere as it is. But just having to think ahead. Harrison eats pureed foods. So if we're going to dinner at somebody's house, do they have a blender? You know, like I have to ask people, do you have a blender? Or I have to bring a blender so that we can puree his food. It's just the interacting part. And I want my kids to have friends and see their family and be social. But it's scary and it's hard.
Yeah. No, and you know, it's kind of, it sounds like there's this, you know, tension both of, you know, what he's physically and cognitively able to do and participate in, but even when there are places that he could go and be around people, there's the interpersonal social dynamic that is just really hard to navigate, both to provide the care and put him in a situation, in a setting that he can be in, but also just, you know, the things that people don't understand, you know, themselves.
Yeah. And I mean, he used to be able to play with toys, which was helpful, but he's lost the ability, like his fine motor skills. So even that, he can't hold a toy, hold a rattle, do anything like that. So back on the previous question, that was kind of the one that stood out to me first, because for his age, you know, that's typical. And people are like, oh, what should we buy him for Christmas? What should we buy him for his birthday? And I feel silly because I'm like, donate to help finding a cure because he can't, not that he shouldn't have toys, but he can't hold them. He can't play with them. I'm not even really sure if he, you know, really understands how they work anymore. So definitely, yeah, the fine motor ability loss and the socializing and helping people understand just what he needs just to leave the house.
Absolutely. Well, thank you so much, Brittany. I see we have a phone caller, Amy from North Carolina, whose grandson Camden is living with GM1, and Amy would like to share some of his experiences of living with GM1 and the impacts in daily life. So Amy, I would like to welcome you to the program. Are you with us?
Yes. Thank you. I was just basically calling in to agree with a lot of the other parents. I'm the grandparent, though, but I'm also the caregiver. When Mandy works, I'm the only one that she will let take care of him, mainly because I, like her, have learned as she's went along what you got to do. And the communication is huge, and the hypotonia is probably the biggest thing that we face right now. We are starting to see some seizures. He actually was just put on them a seizure medication last Thursday and started on Saturday. But the communication things, the mobility, he's the only child, but he's got tons of cousins, and they all love him, and they all want to play with him, and they all do include him. But you can just tell on his little face sometimes he gets really down because he can't play and run like they do. You know, either they carry him where they are going, or they push him in a stroller, or he does have a gate walker that he's able to do most days unless he's really, really tired and he just can't.
Right.
But you can just see the frustration on his face, and that makes us frustrated and sad because he wants to play and be like the other kids, and he's not. And it's not going to get any better. If anything, it's going to get worse. And then it's trying to explain to those kids why he's the way he is and make them understand you have to be extra careful. You have to watch him, and there's some things that they can't do with him because they may hurt him.
Right. And was Camden able to play with his cousins and friends more in the past, and he's lost that ability or those abilities, or is this kind of just as time has gone on, his cousins and friends have been able to start to do things that he hasn't just been able to keep up with?
He's always kind of had trouble with it, but I mean, when he was smaller, it was normal for him to be crawling around them and stuff like that, and they would help him walk and hold on to him. Well, now he's bigger, he's a little bit older, and then they're getting older. So in some ways, it's gotten a little bit easier because the oldest three can actually carry him around now. So, if they're going down the driveway or something to play with a neighbor's cat or something, they automatically just grab him up, take him with him. So in that case, it has gotten a little bit better, but it's making them understand, you have to be very careful and that you can hurt him. So.
Sure. Well, thank you, Amy, so much for calling in and sharing about Camden's experience and kind of building on what we've been hearing, some of these big impacts being on ability to actually engage with and do activities with peers and cousins and the like. So really appreciate that. I do see that we have a number of comments that have also been coming in through kind of the written comment form. So Christine, what are we seeing there?
Nolan from Minnesota has something that hasn't been said. Of all the symptoms, the most significant to my son Riley was the swelling. By the end, he was so swollen, he could barely move, and he couldn't even smile anymore. He couldn't walk, he lost his ability to sit up, and then he lost his eyesight, along with being able to move his arms and smile. So he wasn't able to play anymore or even watch TV. Mm-hmm. So the eyesight and the swelling, those really stand out. And this is type 1 infantile. Mm-hmm. And then we also have Victoria from England, who said the worst thing is she cannot talk about the pain and show where it hurts, and that just seems like a really common theme today.
Yeah. Well, again, thank you to those who are writing in. It's great to kind of hear things that are both reiterating some common things as well as things that are rounding out the discussion, providing some of those things we haven't heard so much about. I do want to take us to one more topic for this morning session that we want to make sure we cover, which is really focusing on life with GM1 in the future. So given everything that you've already experienced and your loved ones have already experienced, what are you worried about or concerned about thinking about, whether it's tomorrow, a month from now or years down the line? So this will be our final polling question of the morning. If you want to pull out your phone, go to that web browser, go to that tab that you have open on your computer, go to www.pollev.com/GM1PFDD. What we want to ask you here is what worries you the most about your loved one's condition in the future? And here you can select the top 3 greatest worries. The options are A, that the symptoms will get worse, B, not being able to communicate health problems, C, falling or other injuries, D, uncontrolled seizures, E, uncontrolled pain, F, impacts on family and social relationships, G, premature dying, or H, some other worry or concern that you have for the future that's one of your top concerns for your loved one. And again, you can select up to the top 3. So we'll give you just a few more moments here to get your responses in. So far, it looks like uncontrolled pain, uncontrolled seizures, symptoms getting worse, and premature dying are all around the top. You know, of course, as results are coming in, they're fluctuating a little bit, but those seem to really be, you know, kind of the top four. And then it drops off, but we're seeing that not being able to communicate impacts on family and social relationships, as well as some other things that we haven't listed in this question are also some of the greatest concerns. We don't see falling or other injuries being rated as a top concern for the future from any of our participants today. So I want you to think about this. Why, you know, what is you know, driving these worries? Do past experiences that you've had inform these worries? And we just kind of want to understand your thinking a little bit. So again, we want to invite you to call in, write in, but at this stage I'm going to start off with our Zoom panel, and we'd like to maybe start with Jenny on this one, thinking about you know, what maybe your greatest worries or concerns are in the future. You know, what stands out in your mind?
Sure, absolutely. And I just want to start off by saying sometimes picking these top three, I find it incredibly difficult as a parent that because all of them are a huge concern for us.
Yeah.
I think in regards to the future, when you get a progressive diagnosis, a disease of a terminal progressive diagnosis, all you think about is the future. What your child is doing now, what they're not going to be able to do, and how much time you have left with them. Not a Christmas goes by where I don't wonder how many more Christmases we'll have with my daughter.
Yeah.
And I think probably the top one of these, though, is the uncontrolled pain. That is something I continue to worry about for my daughter. She grinds her teeth and is clearly in pain with her arms tight, and we continue to try to manage it, but it's very hard because not being able to communicate, it's hard to tell what if it's frustration or pain or an irritation or what it is that's going on with her.
Yeah. So Jenny, it sounds like that worry about the uncontrolled pain, that's something that you're even worried about, you know, kind of currently, and you know, worsening of that, you know, from day to day is a big worry for you.
Absolutely, absolutely. And the other one is probably impacts on family, because as I mentioned, I have an 11-year-old son, and to watch his sister, his only sibling, essentially slowly dying, and the impact that's going to have on him currently and in the future.
Right. Yeah. Well, thank you so much, Jenny.
Thank you.
Lindy, you know, is there something you would like to share in terms of worries, concerns for the future?
Yeah, absolutely. I think one of the things that I frequently think about is as his parent, am I going to know when enough is enough? And if there is not a cure or a treatment, am I going to be able to say enough is enough and just kind of let the disease take my son from me? And do I give up fighting? Will I see it in him that he is no longer wants to fight or cannot fight? Yeah. I think that is a very scary prospect. I never imagined when I gave birth that I would be sitting here today discussing this and thinking about my son's mortality before he hits 14. And I just hope that there will be something that will click within me, or he will be able to show me a sign that if there isn't a really good clinical trial, short of, you know, a full cure, will I see a sign that he no longer wants to continue to fight. So that for me is quite scary. Um, you know, when it comes to my son's future and how to handle it.
Right. And Lindy, are there, specific, symptoms, aspects of quality of life that you, as you were thinking about that and describing that, were kind of driving that, if those particular things were to advance or get worse, any thoughts on that?
Yeah, I think we can all of the parents pretty much agree that the pain levels, but also one thing that my son, especially this past week, has been really terrible, is seizure activity. He's had quite a bit of increased seizure activity this week, and I, you know, can attribute that to pain. So they kind of coincide. And I think if the pain and the seizure activity just, if it I mean, it's so much to bear now. And for either of those things to increase exponentially, you know, to a point that my poor son is just in a constant state of seizure or trying to recover from a seizure or pain. uh, what kind of life is that? That there's zero quality of life there. And I would not want him to suffer in that way.
Sure, absolutely. Well, thank you so much, Lindy, for sharing that. And Stephanie, would like to bring you in on this as well. Thinking about the future, what concerns you the most?
Yeah, I think for me, it's the loss of quality of life and the isolation. I'll never be able to go back to an office job because I'm so afraid that any illness is gonna cause so much pain for him and lead to another significant regression. And so as much as he loves to travel and see people, I have to isolate. And, we're coming up on cold and flu season. And as much as I want, his family to be able to see him, I'm so terrified to go see them because I'm afraid he'll get exposed to something. And so it doesn't feel fair. I feel like I have to choose between exposing him to things and letting him have quality of life, but then being okay if that leads to a significant regression and more pain. And I don't know what the right answer is. And so I'm afraid of that.
Absolutely. Thank you so much, Stephanie. I see we have a caller. We have Melinda from Texas who wants to share some of her fears about her daughter or her granddaughter and some of the symptoms that might come. So, Melinda, I'd like to welcome you to the program. Are you with us?
Yes, I am. Thank you.
Hi, welcome.
I'm the grandmother of a child with GM1, and it's been incredibly painful to watch her regress over the years. We've been watching it for 6 years, and it gets harder and harder. Yeah. I can remember things that she used to do and things that I used to be able to do with her, and they don't exist anymore. And they could be as simple as being able to feed her. She can't eat anymore. Feeding her was a very special time for us because my family's Italian. Food is everything. Yeah. That's how you show love. I can't do that anymore. I can't even pick her up anymore because she's 8 years old. She's too big, and she isn't just dead weight. She's moving around and squirming, and I'm afraid that she'll hurt me or I'll hurt her. So I've lost that interaction with her. And I worry about the future if there's a time when I won't be able to interact with her on any level. Right now, I can tickle her, make her laugh, make her smile, have her enjoy being with me, hold her when she wants to be held, like when she first wakes up in the morning. And I worry that at some time I will completely lose her while she's still with us because I won't be able to interact. I worry about pain increasing and not being able to be controlled as everyone does. I worry about seizures. They haven't happened yet to my knowledge, but I hear people talk about them and it haunts me. I worry that she won't be able to hear, that she won't be able to see. Again, those are things she can still do, even though she can't walk, she can't talk, and she's on a feeding tube, and she can't even have a bowel movement without help from her mother. It's a point where I worry about the quality of her life degrading to where she has no pleasure at all in being alive. And I know we all fear these things. But there's something as a grandmother that you are able to, or unfortunately feel, that parents don't feel, and that is the sadness about what's happening with your children, with my daughter and her family. Watching them go through this is excruciating. You know, I can't help them. You always want to help your children, and I can't help them. It's beyond my control, and it is excruciating. And I just hope, that she doesn't suffer. I just came back from a pilgrimage, and when I go on a pilgrimage or when I meet any person who I feel is able or willing to pray for my granddaughter, I ask them to pray for her. And I notice now that I have refined that. When I went on this pilgrimage recently, I asked that either my granddaughter be cured or that at least she be spared from suffering.
Yes.
I never used to say that. I used to simply say, I pray and I beg for a cure. But now I worry more that even though a cure may not come, that isn't my priority. My priority is that she doesn't suffer. And that is a horrible thing to have to realize that you've come to that point. You've come to that point where what's best for her may not be what's best for me.
Yes.
Her living longer may not be the right thing for her. And it is a reality that I never thought I would have to live through and that my children wouldn't have to live through. I don't think people who haven't been in a situation like having a person with GM1 can possibly understand the depth of the pain and the sorrow that we go through.
No, we can't. And, so I have to just thank you for, sharing that, so much. Everything you've said has been so well said, but also, it's, so devastating to hear and, but so important to hear. So, Melinda, thank you just so much for sharing that. I think that's really all I can say. We do have another caller who wants to weigh in. We have Tania, who lives in Canada and is another grandparent. I think we've actually had a good turnout from Grandparents' Day, which is great to see so many involved in these children's lives. So, Tania, I'd like to welcome you to the program. Are you with us?
I am.
Wonderful. So we'd love to hear from you about any of your granddaughter's experiences that you would like to share, or on this topic of any worries or concerns, if you have anything you'd like to add to that discussion.
Thank you. I can really identify with the last caller. My granddaughter was diagnosed with type 1 infantile GM1, and witnessing the decline of a child with GM1 is really unimaginable. Over time, every aspect of her life became compromised. Trying to help her breathe every day was something that eventually required supporting her with suctioning 4 times daily. Watching her go from pushing herself up and developing normally and then regressing and losing the ability to do something as simple as push herself up during tummy time was heartbreaking. When she lost her ability to hold her head up, it impacted her eating, her breathing, her ability to socialize with us. She eventually had to be partially tube fed to get enough nutrition. Sadly, over time, she even stopped laughing and smiling. And as well, she lost her eyesight, so she lost her ability to hold our gaze.
GM1 impacted every aspect of her life. The toys that she could once play with, she couldn't touch them anymore when she lost the ability to move her hands and her legs. Daily physio helped, but choking and aspirating and difficulty swallowing sadly became more and more a part of her daily life, and every day things just got rapidly worse. In time, she struggled to sleep and would wake up screaming in pain multiple times daily. And I'm sad to say that she did pass away recently as a result of GM1. So now my worries are about the mental health of my daughter, other granddaughters, son-in-law, other family members, and, you know, the impact of this long term on everyone.
Yes. Well, Tanya, thank you so much for sharing your granddaughter's experiences and, you know, with her passings, being so willing to and brave to share that with us. You know, it's the stark reality of this condition, as we heard from the very beginning of this meeting with the clinical overview. And so I just really want to thank you, Tanya, for calling in and sharing all of that. I want to make sure that we do include some of these written comments that we've been getting in. So Christine, what are we seeing from the written web comments?
We have pasted in. We have Maria Jose from Spain, and her daughter has type 3 GM1, and she says the word degeneration still haunts my brain. My daughter still walks, but the agony to think how much time is left, so difficult for her. So this is not just for, you know, infantile or the pediatric forms, but for the type 3 form. And Deborah from Idaho says, seizures cause my son to be so out of it afterwards. And she says, I also feared seizures in their sleep and them passing away in their sleep due to seizures.
Yes. Well, I just really have to thank everyone that has been contributing, our Zoom panel, those of you who have called in and written in and participated in the polling. This has been an incredible morning of really, you know, pulling back the curtain to understand what living with GM1 is like for your loved ones, for yourselves as caregivers, for your families. You know, this is exactly what we needed to hear, and I know it's been you know, difficult at times, you know, to share this and hear others share. So I just really have to commend everybody for you know, all of our discussion so far this morning. We are at the point in the agenda where we're going to take a little break, and then we're going to come back this afternoon and build on this discussion and really start to explore and understand the different treatment approaches and other management strategies that you use to make living life with GM1 a little bit easier for your loved ones, and hopefully, you know, try to help with some of those symptoms that we learned so much about this morning. But for now, we're going to take a 30-minute break. We're going to resume at 1 p.m. Eastern Time. So we look forward to continuing the discussion and hearing from more of you this afternoon. Thank you so much. Good afternoon and welcome back to the externally led patient-focused drug development meeting on GM1. My name is James Valentine. I'm your meeting moderator, and I'm here in the studio with my co-host Christine Wagoner from the Cure GM1 Foundation. We want to welcome you back after such a important and tremendous morning that we had, really understanding what it is to live with GM1. And now in this afternoon are kind of turning the page to now explore the different treatment approaches and your preferences for future treatments for GM1. But before we dive into that, I'm going to turn it over to Christine to introduce our afternoon speaker. Christine?
Thank you, James. I would like to introduce Dr. Janine Jarnes, who will be presenting an overview of the research and treatment landscape for GM1. Dr. Jarnes is an assistant professor in the Department of Pediatrics at the University of Minnesota Medical School. She is the principal investigator of a natural history study for GM1, which first opened in 2009. Dr. Jarnes, take it away.
Hello, thank you for the kind introduction. I will be talking about treatments for GM1 gangliosidosis. There are actually no FDA-approved treatments specifically for GM1 gangliosidosis. There are no treatments approved in any country in the world right now specifically for GM1 gangliosidosis. But this does not mean that patients do not receive treatments and therapies. As many of you know, the patients receive therapies for seizure management, excessive respiratory and oral secretions. They may receive treatments to control muscle spasms and pain from muscle spasms. They may have feeding tubes placed oftentimes in order to provide adequate nutrition. But there are many challenges in creating a treatment for GM1 gangliosidosis that specifically targets the disease. But one of the most prominent challenges is getting drugs that we might give for this disease to cross something called the blood-brain barrier. And many of you are familiar with this, but it's a barrier that separates everything else. It separates substances that are in our body from the brain, or prevents them from crossing into the brain. And it's designed as a protective mechanism. But sometimes when we want drugs to cross, it unfortunately does not allow them to cross. The GM1 gangliosidosis population is also very small, and this makes it difficult to develop an adequate natural history or an adequate understanding of what happens in the disease. And we need a good understanding of what happens in the disease in order to develop an effective therapy. So let's talk about crossing the blood-brain barrier. There's a number of things that make it easier for a drug to cross the blood-brain barrier. I've highlighted here the size of the drug that we sometimes measure in something called molecular weight, and we often use Daltons. Preferably the drugs are less than 400 Daltons, and that makes it a little bit easier for them to cross the blood-brain barrier. And on the lower part of this slide, I'm showing some of the drugs that have been tried to treat GM1 gangliosidosis that are oral drugs taken by mouth. And their weights are there on the right-hand side. You can see there, most of them are below 400 Daltons, and these drugs get into the brain. The actual enzyme that patients with GM1 gangliosidosis are deficient in, they either make no enzyme or they make a small amount of enzyme that's defective, is called beta-galactosidases, as you well know. That actually has a very high molecular weight, approximately 520,000 Daltons. So it does make us wonder with some of the therapies. This is one reason why we just can't give simply an intravenous infusion of the enzyme and hope that it gets to the brain. The weight would be one of the things that would make it difficult for an intravenous infusion of the enzyme to cross the blood-brain barrier. Can we bypass the blood-brain barrier? I'm showing a picture here of a way that the blood-brain barrier has been bypassed in a different lysosomal disease. Now, GM1 gangliosidosis is a lysosomal disease. A different disease called CLN2 uses an intravenous infusion of the enzyme, the very large enzyme, but they infuse it directly into the brain through an access device. And this drug is FDA approved for patients with CLN2. There was at one time some research being done thinking maybe this could be done for GM1 gangliosidosis. It does require repeated infusions once a month for the rest of the patient's life, which can be a major inconvenience. It's quite invasive. One of the beauties of gene therapy is that it only has to be given theoretically once in the patient's entire lifetime, and it may even produce what's very close to a cure. So that is our hope with gene therapy, is that we could find a therapy, a gene therapy that only has to be given once. And maybe it doesn't produce a cure, but maybe it produces something very, very close to a cure so that the child can grow up and have a good quality life and be relatively healthy. And this is our hope with gene therapy. Can we bypass the blood-brain barrier with gene therapy? Well, we do know that there's a gene therapy in clinical trial that is actually being given intravenously. So it's not bypassing the blood-brain barrier, but we're hoping that it reaches the brain in adequate amounts and produces efficacy there. But we can bypass the blood-brain barrier by some of these routes I've shown here at the top of the slide: intraparenchymal, where we go directly through the brain tissue, intracerebroventricular, and that is similar to that reservoir device I showed for the CLN2, and intracisterna magna, which goes into an area in the back of the brain at the base of the skull. There's advantages and disadvantages to all these routes. They're obviously invasive routes. We are seeing more therapies being used now, at least, well, two, using intracisterna magna. And there were some trials with the intracerebroventricular, the ICD, that have been done in some other lysosomal diseases. One of the disadvantages was the needle that they put through the brain to infuse the gene therapy, the needle track around where the needle went in, it did seem to be there was some damage and inflammation to brain tissue around that track. So that was one thing that can be a concern with that therapy. The intracisterna magna or ICM route does not have that concern. What therapies are in clinical trials right now for GM1 gangliosidosis? I've listed gene therapy trials here by 3 different companies: Lysogene, Passage Bio, and Scio. Lysogene and Passage Bio are using gene therapies that are being given through this ICM or intracisterna magna route. These trials are bypassing the blood-brain barrier, and they are currently being tried in children with the infantile phenotype and the late infantile phenotype. They will hopefully be moved into the juvenile phenotype at some point in time also. The intravenous trial by Scio at the bottom of the screen is being tried in early infantile, late infantile, and juvenile. I'm very excited about these trials. I've been working with this disease for a long time, and for so long there were no therapies. There was not even any company, pharmaceutical company, interested in making a therapy. So I'm very excited that now we have companies interested, we have them making therapies, and we have therapies being actually administered through clinical trial. So that is a positive aspect here. Now, all of these therapies so far have appeared to be safe, which is wonderful. We're still waiting to get the final results on them, but we're excited about what we're seeing so far as the data becomes available. There are also gene therapy, many agents that are being researched for gene therapy that have not yet made it into human trials. I'm just showing here an example of one of them called the PS gene editing system that a group at the University of Minnesota is working on, and they are testing this in mice with GM1 gangliosidosis. There are also some oral therapies in clinical trials. I've shown 2 here, Venglustat by Sanofi. I actually had a clinical trial using miglustat and Synergy, which the trial has now been terminated, but that is listed at the bottom of the screen, where we are trying a combination therapy in children, miglustat with a ketogenic diet. There are some other small molecules being researched for GM1 gangliosidosis. I've listed some here, AZ3102 and Tanganol. AZ3102, it crosses the blood-brain barrier. It has sort of a unique mechanism of action. It has been shown to be beneficial in some animal models of lysosomal diseases, including the Sandhoff mouse model, which is a gangliosidosis model, and the Niemann-Pick disease type C model. Tanganol is a drug that's been over the counter in Western Europe for a long time, and kind of through serendipity, it was discovered that it does seem to help with cerebellar ataxia and is now being researched in GM1 gangliosidosis. Pharmacologic chaperones are oral therapies. They may play a role in the future in GM1 gangliosidosis. They can bind to an enzyme and make it work better. So for in the case of GM1 gangliosidosis, they bind to the defective enzyme, if there is some in the patient, like beta-galactosidase, and make it fold into a shape that works better for breaking down substrate. Examples of pharmacologic chaperones for GM1 gangliosidosis include valine derivatives such as NOEV. And what about bone marrow transplant or hematopoietic cell transplant? There's been a number of clinical trials for lysosomal diseases that accept many different types of lysosomal diseases into the trial for transplant, with GM1 gangliosidosis being one of these potential diseases for which a patient could be transplanted. At our center, we transplanted a 6-week-old baby with infantile GM1 gangliosidosis. His older sister had GM1 gangliosidosis and had passed away from the disease at 37.5 months. Keep in mind, the gangliosidosis conditions are uniformly fatal. The patients will die from these diseases. And this is a catastrophic, these are just catastrophic situations, as we all know. In this case, the child had normal APGAR scores at birth, the little boy. Everyone thought, oh, he must be great in terms of his health and not have GM1 gangliosidosis. It was found that he did. He was transplanted. He became fully engrafted. We were excited about that. He had normal beta-galactosidase levels in his bloodstream, but he still succumbed to the disease. It still progressed, and he died at 30.5 months. So the role of transplant in GM1 gangliosidosis is still very unclear. In closure, I'd like to just emphasize that with these clinical trials and with these natural history studies, which are also a form of clinical trial, identifying the outcomes that are meaningful for an effective therapy is challenging, because basically when you put a drug into trial, you can only have 1 or 2 primary outcomes, maybe a secondary outcome or 2 that you're measuring to show efficacy. And I wanted to demonstrate what happened here with one of the children that I have taken care of with late infantile GM1 gangliosidosis. He was started on miglustat therapy and a ketogenic diet. And prior to that, he had lost all ability to walk and talk, but he was able to regain walking skills with assistance with a walking device for a very short time after being on this combination regimen for about 8 months. And I'll just show here, he couldn't walk for many months, and then went on the therapy for a while, got stabilized on it, and was able to actually put one foot in front of the other. And I'll just play a short clip here showing him trying to do
1 foot. Oh, your foot stuck. There you go. Go on. Then I do right.
So as you can see, he was painfully putting 1 foot in front of the other, and was able to do this, and he had not been able to do it prior to that. What this tells me is that these children, their brains are thinking this through, and they want to do these things, and they're limited by the disease. And that was one of the messages I saw in this video. Another message is just the emotions and feelings involved here with this child listening to his father and trying to put that foot in front of the other one. But I was encouraged by the fact that we never thought he could ever put 1 foot in front of the other ever again. We thought that skill was permanently gone. And with some therapy, we were able to see it. Although it was a short-term change, for a little while he was able to do this. It gave me hope that maybe if we had the right therapy, we could see long-lasting changes in GM1 gangliosidosis that are beneficial. And with that, I would like to close my talk. Thank you so much for letting me participate in this activity today and in this meeting, and I will pass this off to the studio.
Thank you, Dr. Grimes, for that great landscape of the current and future treatments for GM1. Really helpful now as we broaden our discussion and bring in the patient and caregiver voice on these topics of treatment approaches. So at this point, I'd like to bring up our discussion questions for the afternoon. These are some of the things that we'd like to hear from you, the members of this GM1 community, to help us really understand. We want to understand what you are currently doing to manage your loved one's GM1 symptoms. So when we talk about this, and sometimes we use treatments as shorthand to refer to the whole constellation of different activities and approaches, sometimes even including adjustments, adaptations, and accommodations that you make to try to make life with GM1 a little easier. So, of course, we are talking about medicines and drugs, both those that are approved as well as those that maybe are experienced during clinical trials and other medical procedures, but also things that are used more broadly, like we've heard a little bit about, and we just heard in the presentation about mobility assistance devices, communication assistance devices, but other more holistic approaches as well, things like diet, and again, maybe adaptations and modifications to the home environment or to the environment outside of the home to make living with GM1 a little bit easier. So kind of keeping in mind that we want to cast this broad net of different management strategies and treatments. We want to know how well do those different treatments treat the most significant symptoms and health effects of GM1. We want to know, in addition to how well those different treatment approaches work, we want to understand what are the most significant downsides to those treatments and how do those downsides affect your loved one's daily life. And then towards the end of our session, we're going to turn towards the future and thinking of products that might be coming down the pipeline that are short of a complete cure for GM1. We want to know what specific things would you look for in an ideal future treatment. And another way to think about this is what factors would be important to you in deciding whether to use a new treatment if it were to become available. So to get us started in thinking through these topics and understanding the GM1 patient treatment experience, we have a set of panelists. We have Ryan, Tom, Rohan, Ronnie, and Nicholas who will be sharing their stories and journeys. So Ryan, take it away.
Hi everyone, my name is Ryan. I live in the UK with my wife Karen and our two beautiful princesses, Nella, age 8, and Savannah, age 4. We always wanted a family, and the day that Nella was born was the happiest day of our lives. Karen had a normal pregnancy, and we had 2 years of joy, with Nella reaching all of her key milestones. We then started to notice her right foot was slightly turning inward as she walked, and we were told she had pigeon toe, and that ballet and swimming would help her grow out of it. At 3, we noticed that Nella was falling more regularly, tiptoe walking, her speech lacked clarity, and she was drooling and had gluea. Nella had her tonsils and adenoids removed and grommets fitted, and although the drooling slightly improved, it did not stop. At 4 years old, following one signal blood test result in September of 2019, Nella was diagnosed with GM1 type 2, which progressively destroys the nerve cells in the brain and the spinal cord, and over time this would rob her of all of her abilities and lead to a shortened life expectancy. This was the day that our world came crumbling down, when our hopes and dreams were shattered and our lives changed forever. We were scared and confused and had entered a world that we knew nothing about, and although we were lucky to have a great team of doctors at Gosh, no one could tell us anything other than we'll manage her symptoms well and we'll make her life as comfortable as it can be. We felt completely helpless. We realised quickly that with rare disease, you don't have time to wait around. We needed to fight for our daughter, and we wanted to learn everything that we could about this cruel disease. On a trip to America to look for treatments, we were approached by the NIH, who were running the only active clinical trial at the time, and they asked us to bring Nella to America for participation. Unfortunately, we had to postpone this due to the COVID pandemic. However, in July of 2021, Nella became screened and became the first child globally to be accepted onto the Sanofi Genzyme Venglustat clinical trial at Manchester's Children's Hospital. This drug is a substrate reduction therapy, which we hoped would slow down or even freeze the progression of the disease. We prayed this would give us time for gene therapy, gene editing, or enzyme replacement to develop, and one day cure our daughter of this horrendous disease. Trial slots were extremely limited, so although we felt nervous and scared, we also felt fortunate to be able to access some form of intervention for Nella. I read the consent form and asked the doctors about the risks and the benefits, and they said little is known, but explained to us the symptoms that were found in mice. We quickly had to get comfortable that the potential benefits outweighed the risk of taking a medicine that had never been taken by a child before. 2 weeks after her first dose, we started to see positive change. Nella started to walk flatter-footed, her speech became clearer than before, and her drooling stopped. We tried to remain calm, but this was a very happy time for us. The most that we'd hoped for was a slowdown or freeze of progression, but we were seeing a reversal. Over the next few months, improvements continued. Nella became more confident in herself, her personality shined through more than ever before, and her family and friends started to notice improvements too. We took Nella back to Manchester, and the doctors were delighted with her completing various initial tests with better results than before on walk test times and peg test completion. 15 months on from Nella's first dose, we have seen no obvious side effects. She is developing well, and from what we can see, there has been no more disease progression. This very small tablet has been a lifeline for Nella and has changed our lives. With the trial due to end within the next year, our attention now turns to be able to continue to access the drug. We are investigating if a trial extension or approval may happen, or if compassionate access could be considered. Karen and I have learned that knowledge and understanding is key to be able to access support and continue to fight for a better life for our daughter, but also to process what is happening in a methodical way. We have learned not to make choices based on emotions, but on as many facts and as much data as we can find. No one can make choices for us, but obtaining views and opinions from as many people as we can enables us to make informed choices based on a collective view. Most importantly, we have learned to enjoy each day as a new day, never looking or thinking too far ahead, and instead enjoying and treasuring every single moment. Nella is a loving and very caring girl, social butterfly that is always smiling and thinking of others. GM1 gangliosidosis is a tough name to pronounce, but not as tough as she is. She is my inspiration, my guiding beacon of light when days feel dark, and I will never stop fighting for her.
My name is Tom. Our oldest daughter, Jenny, is 18 years old and has been inflicted with GM1 since childhood. Symptoms began to present while in preschool. It then took 10 years and over 20 different medical specialists to eventually confirm a diagnosis of GM1. As parents, over this time period, it's been heartbreaking to watch as our beautiful daughter go from meeting all developmental milestones, running, laughing, playing with other children like other normal kids, to today where she's able to barely walk, unable to care for herself, is physically challenged when just trying to eat and drink, and no longer able to speak. Tasks for which all of us take for granted on a daily basis is a struggle for survival for Jenny. Shortly after diagnosis, we learned there is no official cure or treatment for GM1, which is why we're here today. We are presently managing our daughter's GM1 symptoms through the research being performed by the National Institute of Health and University of Minnesota. Our daughter takes the specialty drug Zavesca, also known as miglustat, in conjunction with a ketonic diet needed to subdue the side effects. This particular treatment for lysosomal storage disorders, in theory, may help her molecular cells process beta-galactoside more efficiently to slow down progression. The treatment regimen does not change over time. Other treatments, including providing one-on-one support for our daughter throughout the day. This includes food preparation, feeding, social activities, hygiene, and dress. She participates in the Best Buddy program through her school to have some social outlet with peers. Jenny receives physical therapy to try and maintain mobility as GM1 continues to devastate her neurology and muscle function. This includes home PT she does with her mother and 40 minutes of PT services offered through her school IEP. Jenny also gets occupational therapy through craft activities to provide a creative outlet while trying to maintain what fine motor skills she has remaining. This includes home OT that she does with her family and 40 minutes of OT services offered through her school IEP. Jenny also receives speech therapy to try and maintain not only what linguistics capability remain, but also for nourishment by maintaining her ability to eat. She receives 60 minutes per week through her school IEP. While we have done our best without any additional support for medical treatment, services, or equipment after 18 years, it is clear our daughter is losing the race against time for a cure. A significant reduction in her capabilities resulted over the past 2 years as she was unable to receive IEP services due to the pandemic. She will soon be permanently disabled because of the lack of serious, meaningful, and effective treatments. Ultimately, she will require a feeding tube, hydration IV, 24-hour medical support, and other provisions just to stay alive. Significant downsides of treatment include most medical professionals have no idea what or how to deal with GM1 patients, and frequently it is a struggle to get them to collaborate. Medication side effects of miglustat include gastrointestinal symptoms that often present themselves unexpectedly. Short of a complete cure, things I would look for in a treatment would include genetic screening up front before a couple gets pregnant to determine if they are at risk of having a child born with GM1. We also wish that research would expand human clinical trials to include all patients to ensure the cure is available for all ages. There is still hope for Jenny. However, the continued lack of support only adds to her declining capabilities and increasing the burden on her caretakers. Thank you for your time and hope for a cure for GM1.
Hello, my name is Rojan Vakili. My son Darian is 5 years old and has late infantile GM1. We started to be concerned about his development when he was about 15 months old, and after a 6-month journey, we received his diagnosis. I'll never forget the day we met with the metabolic specialist. The room was windowless, and my husband and I sat side by side listening as he told us about the horrific disease. I was white-knuckling the chair while he spoke so that I wouldn't fall over. When the doctor finished telling us about GM1, he looked at us and said, "Everything I told you today was true last year, but today there's hope. You see, Darian was the first child to be diagnosed right when the first gene therapy clinical trial was in the final stages of approval. When we asked him what we should expect from the trial, he said we were entering a state of great unknown. My husband and I had many difficult conversations after that visit. While we waited for the trial to get approved, we continued to watch him regress. We had to face the harsh reality that a successful trial would be keeping him in his current state. A 3-year-old who can't walk or talk is still cute and physically manageable, but would he be at 20? Were we ready to be lifelong caregivers? Was it fair to him, fair to us? We also feared the safety of the treatment, since it was first in human, but truthfully, that risk wasn't as daunting since GM1 was going to take his life eventually. Ultimately, we decided we could not live with the regret of not trying if the trial ended up successful. Once the trial got approved, the Institute treated another child through compassionate use since she did not meet the eligibility criteria. We held our breath and we waited to see if she survived. Thankfully, she did. We packed up our bags. We headed to the East Coast for 10 weeks. Darian was chosen to be the first patient in the trial. Although we knew the child tolerated the treatment well, we were blind as to how successful the treatment would be. We were told not to compare Darian since he had not regressed as much as she did. Darian underwent 2 weeks of grueling procedures and exams in preparation for the treatment. I have always been Darian's source of comfort when he's upset. He buries his head in my armpit and hides from the world. He spent so much time in that position during those 2 weeks that when the doctors would enter the room, they would jokingly ask if my armpit was ready. Treatment day came, I settled into the hospital bed, holding Darian in his security position as the new genes poured into his body. As I held him, the tears flowed. I cried with relief that we had made it, fear of what the future would hold, and gratitude for all of those that contributed to the treatment. The treatment went smoothly, and he was monitored for a few weeks before we could head back home. We were instructed to do as much treatment and therapy as we could with him. So we enrolled him in hippotherapy and aquatic therapy in addition to the traditional therapies he was already receiving. As the weeks went by, Darian seemed stable. I might even say we saw a slight improvement. We returned for his 6-month checkup and we were all smiles. Everything was looking great. Could this really be happening? Was he going to beat this horrific disease? Unfortunately, a few months after that visit, Darian suffered his first seizure, a major sign that the disease was progressing. In addition to the seizures, we started seeing physical decline. It's been 3 years since treatment. Unfortunately, Darian has regressed significantly. Do we regret what we put him through? No. We had to try. Even if the treatment would have kept him in the state he was in, we would have been ecstatic. He was eating by mouth, sitting, crawling, and most importantly, he was seizure-free. In all honesty, the seizures have been the most difficult part of the journey. Our whole lives revolve around them. We can't go to certain places in fear he will get too excited or stimulated and have a seizure. Caregivers and family are nervous to care for him without one of us present. Therefore, my husband and I have not gone anywhere overnight since diagnosis. Every time he has a seizure, I think, is this it? Will this be his last breath? To me, if gene therapy stopped the seizures, I would consider that a huge success. If a life without watching my son twitch and turn blue for minutes at a time was achievable through the treatment, I would endure those 10 weeks all over again. Thank you.
Hi all, we are Ronnie, Rachel, and our little boy Dean from Malta, and this is our story. Dean was born on 12 November 21, and one can imagine the joy and happiness he brought to our family. There were some early signs that something was not normal, like his crying was very strange. His sucking during breastfeeding was very weak and had hydrocele. But doctors kept telling us everything was okay, but he was just a bit lazy. By end of January, we noticed his eyes were shaking and visited an ophthalmologist, who noticed the cherry red spots in his eyes. The same ophthalmologist had a previous encounter with a GM1 patient a few years back and immediately referred us to hospital. On 2nd February, Dean was seen by a neurologist and told us that unfortunately he had a storage disorder. Most likely it is GM1 Gangliosidosis, which is the most common we have in Malta. At first, we did not realize what this meant, but after further explanation, we knew that this was a parent's worst nightmare. Our boy would be taken away from us in a very short time. Thanks to help from Cure GM1 Foundation, we met other Maltese families who passed through this before us and explained to us that there were some clinical trials going on. In a few days, with help from GM1 Foundation, we spoke to families whose children received gene therapy, gathered contacts and information. In the meantime, we received the official diagnosis, confirming it is GM1, which luckily did not take long, since in Malta they test for it immediately, due to the high incidence of 1 baby per 4,000 births per year. Being only 3 months old, Dean was one of the youngest diagnosed, and this made him eligible for the clinical trials. Obviously, we opted to choose the ones which had the first opening. As we know, time is of the essence for GM1 babies. It was not an easy decision. On one hand, we knew that this was a clinical trial and not a cure, which maybe will not have any impact at all. But on the other hand, we could not live with the regret of not giving him this chance. By end of March, we were on our way to the UK to start the tests prior to receiving gene therapy. Tests including MRI scan, echo test, audiology, ophthalmology, lumbar puncture, occupational therapy, and physiotherapy. It was obvious that Dean was delayed when compared to babies his age, and also had cardiomyopathy, but he was eligible for the clinical trial. On 27th April, he received gene therapy, which was delivered intracisternal, and remained in hospital for 3 nights for observation, and after that we would start going every week to the hospital for blood samples and minor checkups.
This led to the 1-month follow-ups, in which some tests were repeated, one of which was the echo test, and this showed that there were some improvements in his cardiomyopathy, which filled us with hope. Further to that, we were noticing that he was more active, he was grabbing toys and moving them around. Obviously, this could be also normal and not related to the treatment he received. Upon our return to Malta, we would keep on being followed by the local doctors, who would be in contact with the doctors from the UK. This meant visiting the hospital in Malta once or twice a week, in addition to physiotherapy, occupational therapy, and other appointments we had at hospital. It has now been a few months since he received gene therapy, and there does not seem to be any side effects from the actual treatment, but the condition seems that it is still progressing. In addition to the above, he is taking various medications, some of which he takes without complaint, others he does not really enjoy. But we believe that all we are doing is to make his life more comfortable as possible, whilst hoping that gene therapy has worked on him. We hope that in a few years' time, what we are doing today will result in a cure for these children, and if at least this will not save our son, maybe it will save others in the future, and every child will have the opportunity to receive treatments to save their lives.
Hi, my name is Nicholas. Me and my fiancée Jessica live in Sweden and have 3 children with late infantile GM1. Hampus is 8 years old and was diagnosed in May 2018. Julia and Isabella are identical twins and were diagnosed in November 2018. Like many families affected by an ultra-rare disease, we spend a lot of time trying to find the correct diagnosis, only to find they had a fatal disease with no cure. Getting Hampus' diagnosis was difficult because it was so unexpected, but waiting for Julia and Isabella's diagnosis was worse because we knew what was at stake. In Sweden, we're the only family we know of with this disease, so naturally there is little information available. Fortunately, we found the Cure GM1 Foundation and realized that there's an active online community, and here we connected with families from all over the world. We learned about research projects into finding a cure. Some seem to be ready for clinical trials. At the same time, we realized how many families had been waiting on trials to open for years. Our first step was deciding if we should pursue an experimental treatment once available, considering the risks involved. Early 2019, we learned that a gene therapy trial would soon open, one that could potentially stop the disease, but there was only room for a few patients. One concern with participating in a trial is, of course, if a control group is needed. Due to an existing natural history study, a control group was not necessary in this trial. I didn't know about natural history studies beforehand, but now I can truly appreciate their importance, and I'm forever grateful to those who participated. Another concern was that even if all 3 children were eligible, it might not be room for all of them. Then as parent might have to decide who should be treated and who would be left without. No one knew the exact date when the trial would open, but the medical team has set up an email list for those interested to let everyone know at the same time. That email arrived in May 2019. I immediately called to register our children, only to reach voicemail. I called again and again, same thing. I felt we were losing our chance to get into the trial. Eventually I got through and realized I had started calling 15 minutes too early. After I hung up, I figured we were probably among the earlier applicants. A few days later, we were contacted by the medical team who would start testing the children for the trial. The following weeks, we gathered all the medical records to send over to the US. We would also conduct 2 tests from Sweden. The first was the development test, where each child had to score above a specific point for their age. The second was a blood draw to test for antibodies against the gene therapy. Each of these tests could stop our children from participating. Waiting for the results was almost like waiting for the twins' diagnosis. We started to plan for participating in the trial. We had some concerns about the logistics of treating 3 young siblings. Each treatment is supposed to be separated by 3 months, and once treated, one cannot meet an untreated one without risk being exposed to the gene therapy vector. These logistics seemed impossible. The medical team had the same concerns. It was eventually decided our children could be treated within days of each other. Because of delays with shipping the children's blood samples, it took over 6 months to get their blood tested. By that time, it was January 2020, and COVID had started spreading around the world. The pandemic almost put a stop to our participations, as treatments were put on hold and traveling became almost impossible. When the US announced closing the borders towards Europe, we left home within 2 days, arriving in the US with just 3 hours to spare before the borders closed, not knowing how severe the pandemic would be, not knowing when we could return back home. COVID also forced difficult decisions upon us. The gene therapy required the children to be immunosuppressed, and the original treatment plan would put the children without an immune system at the height of the first COVID peak. We had the option to postpone everything until COVID was more under control, but it could mean Hampus would then no longer be able to participate. We decided to go ahead immediately. Because of COVID restrictions, it was eventually decided we would treat all 3 children the same day, separated by 1 hour each, and after the month of immunosuppressants, in the morning of April 28, 2020, our children all received gene therapy. As far as I know, this is the first in a gene therapy trial. The gene infusion itself was unexpectedly uneventful, 25 minutes with an IV drop and then done, but it was still a very emotional day for us. Before treatment, the most difficult thing was dealing with disease progression. It's both terrifying and heartbreaking to watch your child regress, and any new symptom or loss of skill can make it so they're no longer eligible for future trials you might be waiting for. After treatment, the disease stabilized significantly, but we're still struggling with managing 3 children with GM1. Mentally, they're all like 3-year-olds. Every 6 months, we go back to the hospital for follow-ups. From Sweden, that's a 20-hour trip with layovers. After gene therapy, with the kids' immune system being wiped out and COVID circulating, we had to stay in the US for 6 months before traveling back home. These months were both a difficult and wonderful time for us. Difficult because we're so far away from home during a global pandemic with none of our regular support, but also wonderful because we got to spend all this time together as a family. Thank you.
Wow, thank you, Nicholas, and to all of our panelists on this second panel of the day, helping us not only understand your family's journeys with GM1, but really telling us, the decisions that you've made around treatments and sharing then those treatment experiences and journeys with us too. So now we're in the second part of our day where we get to invite all of you in our live audience, the caregivers and family members of those living with GM1, to participate and share your experiences with us together and collectively. Like with the morning session, we'll be going to some polling questions periodically throughout to get a sense of the experiences of our audience and to help kick off the discussions. So we're going to do that now. So if you were with us this morning, you'll know at this point you want to pull out your phone, go to a web browser, open that tab in a web browser on your computer if you're following along that way, and go to www.pollev.com/GM1PFDD. If you just joined us, please go ahead and join as well. This is for our family members, our caregivers of people living with GM1. You can go to pollev.com/GM1PFDD. In this first question for our afternoon session together, we want to know here what medications or medical treatments has your loved one used, either currently or previously, to treat the symptoms associated with GM1? So in this question, we're focused on medications and medical treatments. We'll have a separate question about some non-medical approaches, but please select all of the different medications and medical treatments. The options here are A, dietary or herbal supplements or multivitamins, B, prescription medications for muscular issues, C, pain medications, D, over-the-counter medications, E, acetyl-D-L-leucine, F, miglustat, J, medical marijuana or cannabidiol or CBD or Epidiolex, H, anti-seizure medications, L, melatonin or sleeping medications, or J, other medications that aren't represented by any of the other response options for this polling question. As a reminder, when we have these questions that allow our audience to select more than one option, we're seeing the percentages of total responses, so not the percentage of people who have selected any one option. So you can think of these bars as kind of relative rankings to one another. We don't want anyone to be confused by those percentages that we're seeing. We'll give you a few more moments here to get in your responses, but it looks like currently some of the top medications and medical treatments that are used by the audience represented today are over-the-counter medications, dietary or herbal supplements and multivitamins, as well as other medications, things that we don't have listed in one of the other response options. So we not only want to hear about the supplements and the OTC drugs, but what some of those other things are that weren't listed here. We see after that perhaps the melatonin and sleeping medications, anti-seizure medications, and acetyl-D-L-leucine as some of the top, kind of second tier, most common used treatment approaches. But we're seeing that every single different type of medication and medical treatment listed is used by some number of our audience today. So we want you to be thinking about your treatment experiences with these different products, and hopefully you'll be able to share those with us. We go to the next question. So as I mentioned before we heard from our panel, we do want to talk about not just medicines and kind of medical treatments, but other types of strategies and therapies for GM1. So here we want to know, besides those medications and medical treatments, what have you and your loved one used to help manage with the symptoms of GM1? And again, you can select all that apply. The options are A, physical therapy, B, swim and or writing therapy, C, occupational therapy, D, speech therapy, E, feeding therapy, F, mobility aids, J, a Hensinger collar or other head or neck support, H, a ketogenic diet, I, general diet modifications, J, complementary therapies, K, assistive speech devices, L, ankle foot orthotics, hand braces, or back braces, or M, if you're currently not doing anything, so medication or other types of approaches to try to help manage the symptoms of GM1. So while final results trickle in, it looks like some of our top non-medical medication kind of treatment approaches include physical therapy, occupational therapy, speech therapy, mobility aids, different orthotics and braces, as well as swim and writing therapy. So quite a few of these other types of management and therapy approaches. We see each of the other response options selected as well, with some of those that are less common or used by our audience, including the ketogenic diet, complementary therapies, and no one has reported that they're currently not doing anything to try to help manage the symptoms of GM1. So if we can go to our next polling question. So thinking about all of those things, the medications, medical treatments, other management and treatment strategies, what we want to know here is how well do all of those things together, that treatment regimen, treat the most significant symptoms of GM1, the things that you helped us learn about and educated us about this morning. The options are A, not at all, B, very little, C, somewhat, D, to a great extent, or E, not applicable because you're not using any treatments or other of those management strategies. Basically, you're not using anything that we listed on either of the last two polling questions. So as you're making your selections here and picking, how well you think this current treatment regimen is helping with those most significant symptoms, I want you to think about what symptoms are coming to mind. What treatments, do you view as kind of being either the most helpful or least helpful in relation to those important symptoms? What makes you pick for the about 50% of you that are picking somewhat? What makes you say somewhat? We know that these are somewhat in the eyes of the beholder in terms of picking a response option. And so we want to hear from you. We want to know for the about a little under 1/3 of you that say very little. How do you kind of evaluate how well a treatment regimen is helping with symptoms. And for those of you who are a little over 1 in 10 who say that the treatments are helping to a great extent, similarly, what are your metrics for success? How have those things been helping to a great extent? And so what we do see here is that no one is reporting that current treatment regimens do not help at all. So I want to point that out as well. So now let's open this up. We want to hear from you. We want to hear about your treatment experiences. If you would like to call in and share some of those treatment experiences, what has worked, maybe what hasn't worked so well, you can call in at 1-703-844-3231. Again, that phone number is 1-703-844-3231. If you call in, we'll get you into our queue so that way we can call and bring you into the discussion live here on the program today. You can also, of course, write in. We have that comment box that's under the live stream on the website today. You can put in written comments there, and we'll be reading some of those throughout the program as well. But to get us started, I'd like to welcome our Zoom panel, some of your peers who are joining us here today to share some of their treatment experiences and preferences. So I'd like to maybe start with Jessica. Maybe as we're thinking about these different treatment approaches, let's start with maybe thinking about the things that have been most helpful. And this, of course, might be things that have been helpful in very small but important ways, or if there is something that has been, helpful in a more, extreme way, we want to hear about that as well. But kind of thinking about both medical and non-medical treatments, is there anything that sticks out to you, Jessica, as being the most helpful?
Hi, I'm Jessica. I'm from Ontario, Canada. I'm Lennon's mom. Lennon had early infantile type A, 1A, GM1, and she was diagnosed when she was 6 months old, which was a year and a half ago. And she received gene therapy at 9 months old. And she passed away when she was 17 months old, which was 6 months ago. And we did the gene therapy treatment as well as a lot of physiotherapy and community therapies to help her. I do believe that those helped her. Specifically, we did a intensive type of physiotherapy that a lot of SMA families who have had gene therapy do that we saw online. And it is not very pleasurable for the children, but they do have drastic results from it. And we definitely did notice that in combination for Lennon in the first few months of her gene therapy created a plateau for her. And so instead of a slow kind of progression, she plateaued for a while, and then all of a sudden she had a very rapid progression over a span of about 1 to 2 months. It was just a very quick decline. So that was very helpful. Occupational therapy was helpful for her, as well as daily therapies to help her with her secretions and aspirations, because breathing was her biggest difficulty. We used cough assist, suctioning as her disease progressed, began to become about every hour. And she used BiPAP at night, and that also helped give her more energy during the day, because she did have sleep apnea where her brain would forget to breathe at night. But then in the last few weeks of her disease progression, those things weren't helping her as much anymore, and it just became about really just managing her pain and making her comfortable.
Sure. So Jessica, you mentioned a number of treatments that have helped in different ways. One thing that struck me was you said, that there was this kind of gradual decline that was happening. It was really obvious to you. I think it was, you said after gene therapy, that there was this, plateau. Can you maybe share what were some of the, specific things that made that apparent, that plateau apparent to you, and how did that contrast to what was, occurring prior to treatment?
Yeah, I would say that actually even plateau while sometimes having better days than she would have had before.
Okay.
So a slight increase in abilities in her fine motor skills, her ability to hold up her head, her ability to breathe. which still were quite limited. It wasn't like she was able to sit independently or things like that, but she did have better control. She seemed to be happier, more expressive for longer periods of time. And again, like we know that this disease ranges so differently from individual to individual, so it can be quite hard to compare different disease experiences. But I did reach out and talk to other early infantile parents in the community to kind of understand what their disease progression was like and what was happening, and talking to them the things that Lennon was doing at that time and the way that her disease progressed does sound like it was different. It does sound like she had a better quality of life for a few months, instead of it kind of slowly happening for a longer period of time, if that makes sense. So she would play with her toys, she would hold our finger, she was able to drink orally from a bottle quite well for a longer period of time, which is a big deal. And that really improved her quality of life and improved our ability to connect with her as caregivers, because we're able to hold her and feed her and have that connection and that time with her versus it being all of the G-tube.
Right.
Yeah, things like that.
Yeah, well, thank you for sharing that. And I also want to follow up, when you said that the sleep apnea, was able to be a little bit more controlled, that led to kind of more better days during the daytime because it led to better sleep. Can you kind of talk about, was this something that most days were better? How did you gauge, success, when you were kind of, what was in your mind when you were, telling us about that?
Yeah, it's such a tough one. A lot of the things with this disease that we talk about, it's all the time that it takes to get diagnoses and equipment and things like that. So I think that if she had had the BiPAP earlier on, then that would have been interesting to see as well. Unfortunately, she didn't get it until she was starting to be on the plateau regressing side of things more strongly.
Sure.
And we noticed that when she would have a good night with the BiPAP and settle into it versus fighting it, the next day she would be more refreshed, have more energy, be able to participate in physiotherapy more.
Okay.
Her breathing the next day would be a lot better and clearer. Before, when she wasn't using the BiPAP, we would hear really the rattling and the rasping and the difficulty to breathe a lot more. And once we started using the BiPAP, we noticed how much easier she could breathe on her own during the day and how it helped her lungs become stronger, which was a big positive. Yeah.
Well, Jessica, thank you so much for sharing some of those things that were most useful. I want to bring David into this conversation as well. Kind of thinking about the multitude of things that make up a treatment regimen. Does anything stand out to you as being, most helpful?
Thank you so much, James, and thank you to everybody for having us on. My name is David Law. I'm the father of Violet Law, our baby daughter, who's diagnosed with late infantile GM1. We were diagnosed a little more than a year ago shortly before Violet's second birthday. I should preface this also by saying that me and my wife are physicians. So, in a weird way, we are that intersection of caregiver and patient because, we have this background with us. Initially, one of the biggest things for us were the seizures. That was initially the initial presentation that happened that actually led us to the diagnosis, because the seizures led to an MRI that showed the atrophy that then showed the diagnosis. And I think a lot of that was just titrating the right seizure meds. And, coming from a medical background for both of us, we knew that it's not a perfect science. Sometimes you try different kind of combinations of a few until you get the right combination. And we were very lucky. We actually started her on initially Keppra and Topamax, which are pretty standard anti-seizure medications. And those were okay, but the addition of Epidiolex actually, as a third part of the regimen, actually helped dramatically. And certainly controlling her seizures and having her have these really calm days without any neurologic issues or spasms or anything like that has been a blessing, and certainly has led to a greater quality of life for both her and for us as her caregivers.
Yeah, no, this is really interesting to hear about, David. You mentioned that particularly after Epidiolex was added, that it's been kind of a pretty great response, in terms of seizure control. I want to explore what you actually mean by that. Is that, what kind of what's baseline in terms of either number or severity of seizures, and you know, are she having now completely seizure-free days? You know, how many of those? Maybe if you can kind of, you know, put a little color around that.
Absolutely. Yeah, you know, violent seizure disorder, you know, it first manifested as a grand mal type total tonic-clonic type seizure. But then in between that, we would see these little episodes of, we call them stretching type episodes, where she would either twist her neck or stretch her arms and lasting for a few seconds to a minute at a time. We had EEGs that followed these episodes that didn't tell us that there were actually seizures, but maybe kind of slowdowns of neurologic function. We noticed after the Epidiolex that even those episodes, which were really complete seizures, but just slowing down episodes, slowed down dramatically as well. And that led to more time free of disruptions, more time when she was out of it and more focused on things. And overall, that led to just her enjoyment and quality of life improved. It was almost like magic with the addition of that extra medication.
Yeah, and can you maybe, you know, give an example of the kinds of the kind of quality of life improvement you're talking about? Is there some, you know, something you all are able to do together, or she's able to participate in life a little bit more because of that relief and seizure freedom?
Oh, absolutely. I think when initially you get a diagnosis like this and you look at the websites, you look at all the information out there, you start thinking, what kind of life is this going to be? A child that can't move or talk or lift her head or anything. And for a long time, we thought, well, would this limit us going out and seeing our friends? Would the other kids be afraid of her? Would we not be able to go to Disneyland or do family trips because of the restrictions on her travel? And certainly with the medications controlling those uncontrollable symptoms, seizures and such, and even we have some problems with her secretions and everything, you know, that's really been helpful because now we've been able to tolerate longer trips. We recently had a family vacation in Las Vegas, actually, and we actually had a bunch of family come and spend a week with us out there. And she tolerated the trip fine. And I think that being there, having the medical stabilization opened the door for these much more other greater therapeutic things that weren't medical, that were just seeing friends and family, going swimming in the pool, all those kind of great things that she could now take part in.
Absolutely. Well, thank you so much, David. For the three of our Zoom panelists who we haven't heard from yet, I want to see, do any of you have something that's been helpful that you would like to share about? Just give me a little wave of a hand if you do. All right, we'll just go across the board then. All right, Marilee, let's start with you.
Hi, I'm Marilee. My husband and I have 4 children, 3 of which were diagnosed with GM1. The older 2, there was a little break between our first 3, and then we had a surprise baby. So our older 2 boys were both diagnosed at the same time at ages 5 and 2. And they, our oldest one has passed away in 2020, and then our 3rd child passed away just this last July. And then we have a 2.5-year-old who received gene therapy about 1.5 years ago through the intracisterna magna. My perspective is that the treatments are effective. There's so many different ways of helping these children. Some of them may be effective early on and super helpful, and then midway through the process, different things are helpful, and towards the end, obviously, other things are helpful that maybe weren't helpful at the beginning, and vice versa.
Okay.
A few things that we noticed were when their eyes start going bad towards the beginning, having glasses that can bend, that don't fall, and as they fall and they cut themselves, because they were able to walk, they were able to move around, but the safety issue is an issue. And then helmet, knee pads, bum pads, we found very helpful during those stages. The middle stages were the feeding tube, wheelchairs, support that way so that they can walker, gait trainer, just kind of all that equipment, I guess, thick towels to help with the drooling. And then as they progressed, more peaceful environment, because they tended to be so much more scared, more medications to support. And I should say that the older 2 passed away when about age 10. 10, 11.
Yeah.
And then bowel regularity, that was a huge thing. So we used a lot of different herbal and other type supplements to really help with bowel regularity. That was an issue, and spitting up and all of that digestive stuff to help keep them as comfortable as possible.
Sure. Yeah, Marilee, you've hit on a number of really interesting kind of brought under our broad umbrella of treatment approaches. But one thing we haven't talked about much today is this bowel irregularity issue and treatments for it. So I just wonder if maybe you can speak a little bit to, your children's experience with that. What did that look like, and then what were you trying to achieve with treatments for that?
It was the whole the spitting up, the choking, the bowel regularity. I feel that that was a big issue for us. The feeding tube was great for us for a few years, but when you do that feeding tube, you're kind of force feeding the body with maybe what they're not really able to tolerate. And so you kind of, as the disease progresses, so you have to really be watching that. And we felt that just having that, making sure they were very regular, really helped with the spitting up and the other discomfort symptoms. Of course, there's lots of other symptoms, but we would use like magnesium citrate to just kind of get it going.
Right.
And then we had other things that we just did on a regular basis as well. And I tried not to do too many enemas to artificially kind of continue, just tried to kind of help in other ways to get it going. And then I would use it if I needed to, so.
Great. Well, thank you so much, Marilee. Maria, you also raised your hand. So, can you tell us a little bit about what you found to be most helpful?
Sure. Hi, I'm Maria Bacon. I have 2 children that are affected by GM1. Joseph is 14. Today's actually his birthday. And Oliver is 6 years old. They were diagnosed about 5.5 years ago when Joey was 8 and Oliver had just turned 1 year old. And for Joey, he is, they have juvenile type GM1, and he is a super busy, active kid. He is still walking. He has a little bit of speech left, but it's very hard to understand. But we struggled for a while with him just getting progressively fussier and fussier. He was whining a lot. He was just not the happy kid that we used to know. And so we kind of worked with a doctor trying different medicines for anxiety. And finally, I had seen other families use gabapentin. And I said, why don't we try gabapentin? And she said, sure, why not? And it made a huge difference in his mood. He sleeps better, and he's just a happier kid. And he couldn't tell us, why he was fussy. We didn't know if it was just neurological, he just wasn't understanding things, or if it was pain related. He has, some of the skeletal issues that are common in GM1, and we weren't sure if he was having pain, but it has just made a huge difference in his quality of life. And I have no idea, if that will be a long-term benefit, but he's been on it for, probably coming up on a year now, and it just has really made a huge difference for him in combination with all the other, typical therapies that all, families use. And Oliver, who is 6 now, he was actually treated with IV gene therapy when he was 3 years old, before he was showing any real symptoms of the disease. He had some very slight developmental delays and some fine motor delays, but he was not, regressing in any way. And he seems to be benefiting very much from the gene therapy. He's still making developmental progress at age 6. He's in a typical kindergarten classroom with some supports for his fine motor struggles. And so, you know, obviously we don't know how long those effects will last, but the gene therapy really has been beneficial for him. And I believe that's because he was treated so early.
Sure. So a couple of things I want to explore there with you, Maria. One, with the gabapentin experience, you mentioned that it led to better sleep at night and then kind of a happier, you know, being able to be happier during the day. You know, can you tell us a little bit of like before and after with, you know, what sleep and nights looked like and, you know, what that looked like after gabapentin?
Sure. Joey, like I said, he still walks. He can get himself out of bed. So he was progressing to a point where he was waking up 2 or 3 times a night and he would come and find me. He would get himself up out of bed and he'd come in and turn on my bedroom light and come and wake me up. And we'd be putting him back to bed over and over again during the night. He does take melatonin and that helps him get to sleep, but that doesn't help him stay asleep. And the gabapentin has really seemed to make a difference in how rested he is in the morning. He takes a larger dose at night and then a smaller one during the daytime, so he's not sleeping at school. And his mood is just happier. He used to be fussy about everything. He would, you know, cry when we would brush his teeth, and he'd cry when we'd change his clothes, and he'd just kind of walk around and throw things on the floor. He's kind of like a very tall toddler, and he would just be cranky all the time. And I mean, he still has his moments like we all do, but he is just overall much happier now. He doesn't get upset about every little thing. So that just makes a huge difference.
Wow. Well, thank you for sharing that. Do you want to bring Martha into the conversation as well? Martha, again, you raised your hand there. So what kind of treatment success do you want to share?
Hi, I'm Martha Louderback from Missouri, and I am the grandmother to Bentley Louderback, and he was diagnosed with GM1 type 2. He was treated with the gene therapy in August of last year, so of 2021. And for us, I believe that the physical therapies and the occupational therapies, aqua therapies, were really our biggest friends. He is still doing occupational therapy, physical therapy, and he's also doing feeding therapy. And that one has been a great help to us because we have, up to this point, avoided a G-tube. And we are in discussions of placing one kind of before it's needed, just to be on the cautionary side. But the feeding therapy has really helped with just kind of pushing that off a little bit. But the physical therapies and the occupational therapies, and I'll say from the other side of it too, from my side of it, not just helping Bentley, but helping me have conversations with those therapists, meeting other parents, discussing, you know, Bentley is the only one in this area that I know of that has GM1, but other children at the therapy centers have similar issues that Bentley has. So that connection for me has been very helpful in just being a caregiver. And the, you know, that I know I can talk to one of the other moms there and they understand. They understand the long days, the long nights. And two, the days where you think it's not helping, or, you know, the days that you see that it is, and kind of the back and forth with that. So that the therapies, I would say, has probably been the greatest help. And then just in the last month or so, Bentley has started having seizures. So we are in the beginning stages of figuring out seizure medications. So that was good to hear from David, the different things that, you know, kind of worked for them. And so kind of help us go on our journey with that too.
Yeah. So Martha, one thing I want to follow up with you on, because another thing that it's the first time we've heard about it is this feeding therapy. Can you kind of tell us a little bit about, what feeding and eating looks like, how that therapy has helped kind of continue that and avoid a G-tube, maybe kind of just give us a little bit of color around that experience.
So for us, it was around the beginning of this year that I actually started pureeing Bentley's food, more for digestive aid than anything, because he wasn't chewing as well. And I thought, it's not real good for him to swallow whole pieces of chicken and try to digest them. So I really started pureeing his food more for digestive aid than anything. And then in March, we had a swallow study done, and it did show that he was having some difficulty swallowing. So we moved him to that he doesn't consume anything thinner than a nectar. And so then in the feeding therapies, we work with tools to help his chewing mechanisms. And even though he doesn't chew, it kind of strengthens that, moving the tongue and moving the food to the back of his throat so he can swallow better. And so that's mainly what we work on. And then just also it puts another set of eyes and ears on him. So then, because sometimes when you're in the forest, you can't see the trees. And so then I feel more comfortable that, okay, he is still doing okay in swallowing. He is still having good input and output. And it's just helped a lot in that aspect of it, of just kind of easing my mind too, that I feel like he's eating well, but what does it look like to you?
Right. Oh, that makes a lot of sense. Thank you so much, Martha. I do see that we've been getting some written comments coming in on some treatment experiences. So Christine, I want to check in with you. What are people saying? Any treatment successes?
Yes, Stephanie from Virginia shared, my son received intrasternal gene therapy 2.5 months ago, and I already know it has given him more years of quality of life than he would have had without treatment. Before the treatment, he was on a dramatic decline, rapidly losing skills and worsening quality of life. Since treatment, regression stopped entirely, and he's been able to regain skills like taking steps, eating solids, and increased vocabulary. Even if it doesn't cure him, I would absolutely do this treatment again if given the chance. And we have Honey from Texas, who said the medications help with keeping her bowels moving, combating motion sickness and excess drool, and assisting with sleep. And we have Janine from Germany, who said last June, Leopold received a high dose of IV gene therapy. When Leopold was having a good day, he feels good and is very concentrated. He runs better and longer distances. His hands are not cramped and his speech is clearer and he's more confident.
Wow. Well, thank you for those of you who have been writing in with those treatment experiences. Keep them coming, and we encourage you to call in as well. But right now I want to expand the discussion. We've been talking about the things that have been most helpful, but we understand that there may be things that you've tried that haven't had that same success, or even if they have had success, might come with some important downsides. And so we want to explore that a little bit with you. And so we're going to turn to a polling question to understand some of our audience's experiences and get everybody thinking about this topic. So go ahead and go back to that browser on your phone, that tab in the browser on your computer. Go to polyev.com/GM1-PFDD. Here, we want you, again, thinking about all of those different types of treatments that you and your loved one are employing. What are the biggest drawbacks of those treatment approaches? And here you can select up to 3. The options are A, they're not very effective at targeting or treating the target symptom. B, they treat some but not all of the symptoms. C, the high cost or copay, or that it's not covered by insurance. D, limited availability or accessibility. E, the side effects. F, the number of pills, medications, or preparation that goes into the treatment approach. G, it requires too much effort or time commitment. H, some other biggest drawback of a current treatment approach that represents one of the biggest drawbacks but is not listed in the response options. Or I, this is not applicable because your loved one is not using any treatment approach. So again, as you're thinking about these options, think about, why are you choosing these as the biggest drawbacks? What experiences are popping into your mind as you're making these selections? We really want to know the why behind, these types of answers. But while some final results are trickling in here, we're seeing what I think is clearly the biggest drawback being reported by our audience, being that the treatments that we have are only treating some, but not all of the symptoms. We see after that some of the other biggest drawbacks being reported being the limited availability or accessibility. So we certainly would like to hear a little bit about what you mean by that, what types of treatments are limited or inaccessible to you. We see also that the treatments that do target certain symptoms aren't very effective at treating that particular symptom, as well as the fact that treatments require too much effort and time commitment. But again, each and every single one of these things here is in somebody's, or in this case, I think in many people's top 3 biggest drawbacks. So at this stage, we want to invite you to call in and write in and share some of these treatment downsides. If you'd like to call in and share your treatment experiences, you can do so at 1-703-844-3231. Again, that phone number. We'd love to hear from you, sharing your treatment experiences, 1-703-844-3231. But to get us started as we kind of expand this and talk about some of those things that haven't been so helpful or come with important downsides, we're going to come back here to our Zoom panel to kick us off on this topic. I guess I'll ask, do we have anyone that wants to volunteer to go first on this? I saw David, your hand pop up there. So David, why don't you kick us off talking about maybe what hasn't been quite as great of a treatment experience?
Thanks so much, James. So one of the drugs we did try initially was one of the substrate reduction medications, miglustat, which is meant to cross the blood-brain barrier and break down some of the substrate buildup. And it was tolerated initially okay, but unfortunately it did come with a lot of GI side effects, a lot of gas and diarrhea, to the point where we almost got kind of afraid of her being dehydrated and actually needing IV fluids. So unfortunately, we had to stop that medication. However, we were recently enrolled in a clinical trial for the other small molecule Gangliostat, which she's been tolerating much better. So that does give us some hope that perhaps the benefit seen in miglustat would be seen out in Gangliostat without the same side effect profile.
Sure. And can you just give us a sense, how long did you try miglustat, and was this kind of, were those side effects kind of there from the beginning, or did they kind of come on and then got to a point where they just weren't tolerated anymore?
It was pretty significant initially. It was almost as if we started giving her the drug and then her GI system just couldn't digest those excess carbs and create gases and such. And then we would definitely lose the water and then through the GI losses. So it wasn't like we tried a while and then eventually tore it off. It really was immediate.
And would you say, I don't know how long you're using miglustat, but was that something that you felt like you used long enough you could assess whether or not it was working, or you had to kind of stop it before you had a chance to evaluate that?
I'd probably say stop before we had a chance, just because whatever improvements we could have seen were probably offset by the fact that she was dehydrated and not having a good time with the medication itself.
Okay. Yeah, well, thank you very much, David. Very helpful to understand. Marilee, kind of want to bring you into this. Again, whether it's something that maybe wasn't as useful, or even if it was useful, had a downside, what comes to mind for you?
I thought of 3 different things. One helpful but downside is the gene therapy. Helpful. And we think we think being helpful a little bit early to tell as far as comparing our youngest to our older two and where he's at with in the development and everything. We're seeing some help, but it's still ambiguous. And the downside is just intense time commitment. It's an intense time commitment. And it's emotionally, as well as, you know, a lot of different factors as we've seen some of the speakers. The other thing I thought of was the back brace. When my oldest son was 3, he had developed kyphosis, his lower spine, went to an orthopedic surgeon, provided a back brace. Those back braces that we received, I felt like did more harm than good and didn't help at all with the situation, at least in our case. It just made it harder for him to walk and avoid falling because he was so stiff. And so he was still walking at the time, but he was falling frequently, and it just made it more dangerous. We did give it a good effort, didn't notice any improvement there. Also, using a wedge or a hospital bed until they were not able to, until end of life. We did appreciate those things at end of life stage, but when they were still mobile and agitated and really struggling that way, we found the most effective was just their crib, which they were still small enough to use. And I had padded it all up, put fabric on the sides, and had a nice special mattress with extra padding there that they could be safe. And we really couldn't figure out a way to elevate them to help with reflux and stuff in a way that was safe, where they wouldn't get themselves caught or stuck or hurt themselves in the night.
Right. Marilee, one follow-up question for you. You mentioned with the gene therapy treatment that it's been helpful, but there have been some kind of downsides, and one is that it's been, you know, kind of the care and treatment has been pretty burdensome. Can you maybe share what you meant by that? And, you know, is that, you know, how does that factor? I mean, is that something that, you know, it's there, but it's something that's acceptable given the trade-offs and potential benefits of gene therapy, or is this something that you know, you wouldn't do again because of those trade-offs, those downsides?
I would definitely do it again. I think it's just something to know, keep it with your eyes wide open going into it, and get the support and whatever that you need to help you to get through that experience. Because even though they've taken such good care of us, it's just the nature of being in a study like this. It is intensive. There's a lot of repeated visits, especially when you're traveling a far distance. The initial, you know, stage is the biggest time commitment. And then just, you know, when you have, in our case, a toddler who can't fully explain what's going on and they don't want to cooperate, and then you're kind of having to do all these things in an intensive short period of time, all these different tests, it can be hard. And on the rest of the family. But now that our other 2 children have passed away, it's a lot easier for our family to manage going. Now we can go together, and we can support one another in this.
Sure. Thank you so much, Marilee. I see that we have a phone caller. We have Cindy from Oklahoma that wants to share, you know, some of her perspectives on treatments and I would say a lack thereof. So we'd like to welcome Cindy to the program. And Cindy, are you with us?
Hi, I sure am. I just wanted to comment that since this program is directly connecting to the FDA, I wanted to let the FDA know that some of us who have older children with the disease of GM1 are really frustrated by the fact that none of the clinical trials or the treatment options that are being trialed out are open to older kids. And some of us feel like that we know our children well enough that we really think that they would be able to tolerate the treatment and that it would actually improve their condition a lot. So in my case, for example, my son is one of the few that responded really well to miglustat.
Mm-hmm.
So we're particularly interested in other drugs that are similar in chemical makeup to that and would love to be a part of a trial. But a lot of the drug companies are opening those only to younger children or infantile form. We just want the FDA to know there's a lot of patients out there. And even though we understand the logistics and the desire of some drug companies to treat newly diagnosed or really young patients, it's frustrating for older patients to have no treatment options available to them and to not even be considered for the trial.
Yeah, so Cindy, it's of course very helpful to hear that, the families and the children who are your child, he's not a child, he's 34, but you're are interested and willing to participate in clinical trials, are willing to undergo some of the, those trade-offs. We just heard Marilee talk about some of that. We've heard a little bit about that in other statements. But what I'm really interested is, you mentioned, that miglustat, you kind of have been one of the responders to miglustat, and that's been helpful, and that's kind of informing your interest and willingness to participate in other trials. Can you maybe just share a little bit about how miglustat has helped, and that I think will help put your kind of comments and interests in a clinical trial into a little bit more perspective for us?
You bet. Well, miglustat is actually a drug that I followed online for a long time before it became available in the United States. And it's a very long story how we ended up deciding that drug might be effective. But we did start taking it about 5 days after the FDA fast-tracked it and made it available for another disease. So we used it off-label, and my son had a dramatic response. I mean, this was a child who was sitting in a wheelchair in almost like a catatonic state, who, once he started taking miglustat, it was like miraculous how he came back to us. I mean, he started interacting again. He started doing play with his little characters and his toys again. And he started getting down on the floor and wanting to crawl around again. So for us, it was a miracle drug. And I do understand that it hasn't had that same effect for other children, and that's something that makes us very sad. But for us, we know that for some reason it worked with his particular chemical makeup.
Sure.
Cindy, so that's the track we'd love to follow.
No, for sure. And I think that is so helpful to hear, both in terms of the treatment experience, but again, your thoughts and preferences for participating in a trial. I want to thank you so much for sharing that. I do see we have some written comments on this topic of either things that haven't been so useful or treatment downsides. Christine, do you want to weigh in and share some of that?
Yes, so there's some interesting ones here. Rasim from New York didn't mention treatment, but the difficulty in getting diagnosis. So he said, it's unfortunate we reached out through our primary to determine the type of GM1 that our child had in 3 of the trial centers, and NIH all had differing opinions of what type the GM1 their child had. And I think that resulted in difficulty in being able to enroll in the trial. And there's other similar themes. Heather from Canada, also, for such a rare and fatal disease, the difficulty of not being selected and meeting criteria was just very devastating. Another interesting comment, Jenny from Texas, and I think this points to the constellation of symptoms. Some of the treatments for one symptom exacerbate other symptoms. For example, scopolamine used for motion sickness and to reduce drooling exacerbates constipation. Yeah. So just that difficulty, I think, of when people are selecting how to address all these different symptoms.
Right. Yeah, I want to thank everyone for weighing in on this. So as we near the end of our time, we do want to make sure we spend a little bit of time understanding what this community's preferences would be for a future treatment, really thinking about something that would be short of that complete cure for GM1. So for the last time today, we're going to ask that you pull out your phone, go to that tab in your web browser, go to www.pollev.com/GM1-PFDD. Here we want to ask one last question, which is, short of that complete cure, what specific things would you look for in an ideal treatment for GM1? And you can select the top 3 things that would be kind of your top 3 priorities. The options are A, slowing or stopping disease progression, B, improving expressive communication, C, improving receptive communication, D, lessening of pain, E, improving mobility and coordination, F, improved ability to swallow, G, improving cognitive functioning, H, improving sleep, I, decreasing seizures, J, increasing lifespan, or K, some other specific thing that you'd be looking for in a future treatment for GM1 that's not otherwise represented in one of these response options that we have. And again, please select up to the top 3 of those. All right, so I promised early on that questions would get harder as the day went on, and this is probably the hardest, to just limit this to 3 treatment goals. But as any final responses trickle in, it looks like the top choice from this audience in terms of top treatment goal would be slowing or stopping the disease progression. We do see a number of the areas where individual kind of symptom or functional improvement would be important. With lessening of pain, improving expressive communication, improved cognitive functioning, but really every single one of those being selected by some number of our audience as being important, along with decreasing seizures. And we see a number of people are selecting increasing the lifespan as well. But what really stands out is just how far above all of the other responses, slowing and stopping of disease progression, is in our audience today. If you would like to share your thoughts on what would be an ideal future treatment, please, we would welcome you to call in. That number again is 1-703-844-3231. Again, 1-703-844-3231. To share your thoughts on what would represent an ideal future treatment. But we're going to, one last time, come back to our Zoom panel here and get some of their thoughts on this. Maria, perhaps we can start with you, thinking and weighing some of those different goals that you might have for a future treatment, knowing that, of course, the ultimate goal is a cure. What kind of the top thing that stood out in your mind?
For me, really an overall slowing of the disease progression, of the degeneration, would be huge if we could just kind of put a pause or slow down, everything. That would be ideal. And short of being able to slow everything, I think that being able to slow or improve the cognitive decline, because even if, communication and speech is huge, but even if a child loses their speech, if they still have a high level of cognition, there are other ways that they are able to communicate via, speech devices and eye gaze systems and such. And of course, mobility is really important too, to be able to do what they want and get in the positions that they want and get around is very important.
Yeah. So it sounds like cognition and mobility, both, of course, if there could be improvements, but those would actually also maybe be some of your targets for keeping or slowing the loss of current function. Those would be two priority areas for you.
Absolutely.
Yeah, well, thank you. Martha, I want to ask you this same question, kind of weighing, some of the different treatment goals that we might have. What would represent an important, treatment in your mind?
Well, for me, I did choose the slowing of the progression or the stopping, but I'll kind of clarify that.
Yes.
I chose that for the stopping side because for me, the slowing of it, I don't want it slowed down. Like if it's not going to stop it, I don't want to prolong it because Bentley does struggle. So I don't want it slowed because I don't want it continued. So I chose it for the stopping aspect.
Yes.
Not the slowing aspect. The lessening the seizures for me, like I said, the seizures are fairly new for us as far as the severity of them.
Right.
So that's an important one for me because we are having trouble managing those. But even though Bentley had the gene therapy, his regression has progressed dramatically in the last year. When he was treated, he could still hold his own sippy cup and drink, and he could sit up and roll. And now we've lost all of that. And so for me, I don't want to prolong that. There's a lot of times that I don't know if he's in pain or not.
Right.
So if not knowing that, I would choose either stopping it or nothing. For me, it wouldn't be a slowing of the progression, but I also know that for children who are older, that is a different viewpoint.
Right.
Because, you have maybe a higher quality of life when they are more mobile or can still speak. And that is an important aspect. But I know for us, it's that's probably the biggest thing for us is that we just, if it can't be stopped, we don't want to prolong it. And our main focus is quality of life for Bentley, not necessarily quantity, but quality.
Right. Yeah. No, thank you, Martha. And, we totally understand all day, but particularly this question, every answer is personal and depends on the personal situation of where you're at. And, so I think that hopefully goes unsaid, but I appreciate you saying it, because that we understand that, for everyone, and that's why we're asking everyone to weigh in, they're going to have a different personal take on what would be meaningful. So I would like to ask Jessica, as we're thinking about this, given, your experiences, what would have represented something that's really a meaningful, treatment outcome that's short of a cure?
Thank you, Christine and James, and thank you for everyone who shared. I think the biggest, I'm going to kind of answer this question with two answers in one. The biggest limitation right now and the biggest best possible outcome, the truth is that this disease is death by 1,000 knives, and it is everything, even the questions of all of the symptoms, like the list goes on, and it doesn't even begin to encompass the daily life with this disease. It is just, you can't put it into words. It is it completely takes over and demolishes your life and your loved one's life. And any option of any type of treatment that a parent or caregiver or individual feels that would benefit them should have the right and the opportunity to choose that. So the biggest limitation here is the inability to have access to that for everyone. And the truth is, it's so hard because it is such a multifaceted disease and it is really hard to treat. I really believe that there needs to be more options for parents to be able to try different things. And there are such limited clinical trial spots for everyone, and the caller who brought in an adult being able to try things. So, and it sounds like people are having very different responses as well. So for parents, for families to be able to make the best decision that they can make for their loved one is what should be able to happen. And even moving forward, I think that gene therapy or a small molecule therapy are not going to be enough. We're probably going to need those two things together to be able to impact and take this disease on, because it is so severe. So the faster that we can have access to try different things and use those things together is the faster that hopefully we can start to chip away at being able to do something, because right now our community has absolutely nothing.
Yeah. Well, thank you so much, Jessica. And I really want to thank all of our Zoom panelists for everything that you've shared and contributed throughout the day. I do see that we have a number of experiences that have come in through our written comments. So Christine, I want to kick it over to you to share those with the audience.
Yes, we have Patandra from Minnesota, and I think this is just really representative that anything would help. I would have loved for Jacoby to have head control. It would have made life a lot easier. So that's just one thing she wrote about. Belinda from Texas has a very similar sentiment to Jessica. Clinical trials for GM1 have been including only children who have mild symptoms or are pre-symptomatic. There are many parents of children with a more advanced stage of GM1 who would like the opportunity of trying some kind of treatment. They realize the risks, but the alternative is simply watching their children regress and waiting for them to die. Since GM1 is universally fatal, giving them even a long shot of a chance to improve their quality of life should be available.
Yeah, and Christine, I wonder, were there any comments on potential, views on, either in, participating in trials or things that would make, investigational therapies more, kind of acceptable to our audience?
So Nolan from Minnesota, cites the fragility of the infantile patients. So he really thinks that invasive surgery for his son would not have been an option. So that's an important consideration.
Sure. Well, thank you. So at this point, I know we've gone a little longer than we said, but I thought it was really important that we heard from as many voices as possible. But this concludes the part of the agenda where we're asking you to share your stories, your experiences, your preferences. And as your meeting moderator, I really would just want to pause before we move into closing the meeting to really just thank all of you. Both the morning and this afternoon session have been incredibly enlightening, to someone like me who's not part of your community. I can't imagine the things that you experience, and you brought them to life and set out the goals that we wanted, set out at the beginning of this meeting, of wanting to, know and know, in a very real way what life with GM1 is like, really hearing about those most serious and significant impacts, and then in this afternoon understanding those gaps and unmet needs that you have, and I think every person that shared today shared very personal and oftentimes very difficult experiences. And again, just as your moderator, I can't thank you enough for being so brave and willing to do that. It's had a huge impact on me, and I know that it's going to have a huge impact on those who are making decisions in industry, as regulators, and more broadly in this ecosystem. So just, again, one big, tremendous thank you to all of you. So at this point, it's my pleasure to introduce our speaker who will be giving summary remarks, a truly impossible task to try to summarize everything that was covered in today's meeting. But he is uniquely situated to at least help us, have a good recap that will hit on some of those major key themes that we heard. Our speaker is Larry Bauer, who's my friend and colleague. He spent 17 years at the National Institutes of Health, where he was a research nurse and worked a lot in pediatric settings. He then went to the Food and Drug Administration, where he helped co-found the Rare Diseases Program and worked as a regulatory scientist for 10 years. And since he left the agency, has been working to help bring the patient voice to decision makers and was a big part of helping plan this meeting. So please join me in welcoming Larry Bauer. Larry, take it away.
Yeah, thank you so much, James. It's been an incredible day, a very emotional day, and I will do my best to provide a summary. This is a high-level summary, so there are a lot of points that I won't be able to cover, but please know that anything that I missed will be included in the Voice of the Patient report that will be written after this meeting. So this morning, we opened the meeting with Christine Wagoner, who's the co-founder and president of the Cure GM1 Foundation. Christine's also the mom of her daughter Iris, who's living with GM1. This was followed by a presentation from Dr. Wilson Bryan from the FDA's Office of Tissues and Advanced Therapies in CBER. Dr. Bryan shared that PFDD meetings are valuable to the FDA to learn from the experts, the caregivers of people living with GM1, and that this helps facilitate treatment development, helps them design clinical trials, and helps in their review of new drugs for GM1. After Dr. Bryan, we had a clinical overview of GM1 that was provided by Dr. Cynthia Tift, who's the Deputy Clinical Director of the National Human Genome Research Institute at the National Institutes of Health, and a big supporter of the GM1 community. She talked about GM1 being a genetic lysosomal storage disorder of ganglioside degradation. She said it's a rare neurodegenerative disorder that's uniformly fatal, and it has no FDA-approved therapies. There are 4 subtypes that happen on a continuum of severity, and earlier onset seems to be more aggressive, and the adult form is very rare. People initially present with gait disturbance, dysarthria, and stuttering. And it's really challenging to get an early diagnosis. And Dr. Tiff emphasized that newborn screening is really needed. Then we moved into hearing from the caregivers about health effects and the daily impacts of GM1. First, we heard from Douglas, who's a caregiver to his 14-year-old daughter, Iris, who has type 2B. Iris started life with no health problems, but started showing symptoms around age 5. She developed gait disturbance and declined so that now she cannot walk, talk, eat, or make herself comfortable. She has seizures and needs a feeding tube. He states, with this disease, you learn not to hope for much because it will almost always lead to disappointment. Secondly, we heard from Abby, who's a mom to Daxton, who was diagnosed with early onset GM1, type 1, at 4 months of age. He first showed signs of aspiration, low oxygen levels, and low muscle tone. Eating is his biggest problem, and he also has developmental delays. Abby says, my biggest fear is that Daxton will not have a long life and will lose the abilities that he now has. Next, we were joined by Bence from Hungary, who's dad to his daughter, his 2-year-old daughter, Biborka, that has type 1 early infantile. She presented with hearing and visual disturbances. She had a rapid decline and needs a G-tube and 24-hour care. He says, we don't know what the next day or even the next hour brings. Next, we heard from Megan, mom to Marley, that has type 2A late infantile GM1. By age 3, she could not walk independently. Seizures have been debilitating, and she sometimes stops breathing. Lately, her pain has been severe. She says that GM1's a terrible, non-relenting disease that will try to steal everything from our daughter. And lastly, in the morning, we heard from Kylie, who's mom to Kinley, age 9, and Kennedy, age 6, both with type 2B juvenile form of GM1. Communication, mobility, and cognition are the 3 biggest symptoms that impact their lives. They've progressively lost abilities they once had, which is heartbreaking. And she worries that they'll get to a point where treatment will no longer help. So we heard some of the themes. We heard GM1 insidiously robs people of mobility, speech, and the ability to care for themselves. Some families have multiple affected family members. We also heard that GM1 has a relentless progression from onset, which is a great concern for the future. We heard from parents as well as grandparents that shared how painful this disease is for the entire family. After our lunch break, we came back and began a discussion of GM1 treatments. Our first panelist in the morning was Ryan, who's dad to Nella, who's aged 8 with type 2B late infantile GM1. She was diagnosed at age 4. She's been in a clinical trial of Gangliosidosis, which is a substrate reduction therapy. She's improved on this treatment without side effects, and they're seeking a trial extension or compassionate access to continue treatment. Next, we heard from Tom, dad to Jenny, who's 18 years old with type 2B. She takes miglustat with the ketogenic diet. This is an ongoing research study. She participates in the Best Buddies program for support. She gets PT, OT, and speech therapy, which we heard from many families. Her symptoms have worsened, though, over the last 2 years, and they feel like they're in a race against time. Next, we heard from Rojan, who's mom to Darian with type 2A late infantile. Darian was the first patient in a gene therapy trial, even though outcomes were still unknown. He did not have side effects, but he gradually started to decline, but they have no regrets from being in the trial. If there was a way to stop seizures, she said this would be a huge success to them. Next, we were joined by Ronnie and Rachel from Malta, who are parents to Dean, who was diagnosed early at 3 months of age. He received gene therapy very early and had improvement in his cardiomyopathy. His symptoms, however, seem to be progressing, but he does not have side effects from the gene therapy, and they hope that he'll make improvements in the future. And our last morning or afternoon speaker was Nicholas, who spoke to us from Sweden. He's dad to Hampus, who's age 8, Yulia, and Isabella, all 3 with late infantile GM1. All 3 of his kids, he got them all enrolled into a gene therapy trial on the same day, and they were given gene therapy just an hour apart, which he thought was history-making. After treatment, the disease stabilized significantly, but he says care is still difficult since they all are mentally like 3-year-olds. So each of the major symptoms, including impaired mobility, cognitive decline, seizures, pain, and communication issues, they have incredible quality of life impacts, and the treatments are mostly palliative. They include PT, OT, speech therapy, orthotics, and there's no FDA-approved treatment for GM1. We've heard about the tremendous unmet medical need within this community. People said they would be, anything that they could get that would help them would be meaningful. Many families expressed willingness to be in research, even if it only helps people in the future. So we heard gene therapies in experimental stages, and results have been varied. One family used gabapentin, and we also heard about a trial with miglustat combined with a ketogenic diet, which is currently being studied. And now I'd like to close the meeting by turning it over back to Christine in the studio. Thank you.
Thank you for the summary, Larry. This has been an incredible day of hearing personal insights to help us all better understand GM1 and its impact. Thank you to the FDA for giving us permission to hold this meeting, and to the FDA staff who tuned in today. Special thanks to Shannon Sparklin and Karen Jackler from the FDA who guided us through this process. Thank you to Dr. Wilson Bryan from the FDA for your perspectives on the importance of externally led patient-focused drug development meetings. To Dr. Tift for the very interesting clinical overview of GM1, and to Dr. Jarnes for outlining the treatment landscape. Thank you to the Dudley Digital Works media team for all of their work helping with the meeting, and to James Valentine, Larry Bauer, and to the Cure GM1 Foundation team. Thank you to our supporters and partner organizations. This meeting would not have happened without you. But a huge thanks goes to you, all those with GM1, and their caregivers who shared your experiences, and to those of you who called in or wrote in giving your insights. This meeting couldn't achieve the goals if it weren't for you. We'll compile all of the information from today into a Voice of the Patient report, which will be available on the Cure GM1 Foundation website, along with a recording and the transcript of the full meeting. There will also be a link from the FDA website. The web link to submit comments for the report is open for another 30 days, so please consider submitting additional comments, which will be added to the Voice of the Patient report. The on-demand video, along with a list of supporters and partner organizations, is publicly available immediately at the same link on our website, curegm1.org/PFDD. Thank you to everyone. The impact of this meeting will be felt for years to come.